Prima era spento però.
Allora lui si
Ok, lo metto qua, va bene, perfetto.
This session, this graduation session. Apologies that there was a little delay, but we had to change this session, this graduation session.
It's me.
Apologies that there was a little delay, but we had to change this session. All right. We had some little delay, but I hope we will be able to finish on time, to leave you all the time to spend enjoying this wonderful day with your families and with all the people you love. Talking about joy and celebrations, I'm sure I know you one by one, and by knowing you, I know for sure that your families and friends are as sweet, as responsible as you are. But I must tell you that remind you that we are in hospital, so you are free to enjoy the day, you are free to express your happiness, but please do it outside the hospital. This is something which I'm really asking you with all my heart, from the deep of my heart. And also people who, I would like people not to go back and forward. If you are here to listen to your candidate, please stay here. There is air conditioning. It's better to stay inside than outside. Stay here and don't go outside and inside, because this could create problems to the other candidates. And I think you all agree with me, today they are all our candidates. So, and I think it will be moving, because I will miss you so much. I will miss you so much. Anyway, today we have, as a representative of our Ordine dei Medici, Dr. Felice De Ruggero. He is a young and enthusiastic doctor. You will love him. I always enjoy when he's here, because it's really a representative of the way you want to be when you will be doctors. And by looking at the committee, even though sitting far away, I can see that you choose excellent examples for your thesis. I think all the teachers who are sitting here were for you an excellent guidance and an example. So we can, having said that, we can start. There will be some adjustments, but basically the order remains the same. So I'm going to call the first candidate, Anastasia Erini Msura, who did her thesis work under the supervision of Professor Fabrini, who's going to introduce her.
Okay. Okay, good morning everyone. Anastasia has been a very enthusiastic student, really enthusiastic, even too much sometimes. And she has worked very hard on this complex topic, in which she will show us how we can use different techniques, neuropsychological, to understand how cognitive dysfunction influence multiple sclerosis patients.
Okay. Good morning, everyone. I would like. Oh, sorry.
Take the microphone. You have 10 minutes, including discussion. And
Okay.
you know we love to hear you.
Okay, good morning, everyone. First of all, I would like to thank my advisor, Prof. Fabrini, and my co-advisor, Dr. Gina Ferrazzano, for their guidance. I would also like to deeply thank the president of our degree program, Prof. Giulia Damati, who has always supported us throughout these years, and of course, the entire committee and everyone else for being here today. So let's begin. I will be talking about digital cognitive rehabilitation in multiple sclerosis using the MIA brain training application and our one-year longitudinal clinical, neurophysiological, and neuropsychological study. Multiple sclerosis is the most common chronic inflammatory demyelinating disease of the central nervous system, and approximately 60 to 70% of MS patients experience cognitive decline, often independently of physical disability. In fact, it's important to note that cognitive deficits are not a function of disease duration, as they can even emerge early or in patients that have been diagnosed with isolated syndromes. As you may see at the slide, the most commonly affected cognitive domains are information processing speed, working, episodic, and verbal memory, attention and visuospatial skills, yet what's generally conserved is language and semantic memory. Nowadays, there are no approved pharmacological treatments for tackling cognitive impairment in multiple sclerosis. So what we can do is monitor our patients through standardized neuropsychological testing, neuroimaging, and what we're entering nowadays, this new era of EEG microstates. So what are EEG microstates? They are brief periods of stable brain activity, and they reflect the coordinated activation of large-scale functional brain networks. As you may see on the slide, they can be characterized by different parameters, but what was most important to us was mean duration and global field power, which is a measure of the overall strength of brain network activity. Previous literature in multiple sclerosis has shown that alterations in these EEG microstate parameters and dynamics have been associated to cognitive dysfunction. The standard model that you see on the right, developed by Custo, includes 7 EEG microstates, yet in our population we identified 6, out of which A, B, C, and F were the most relevant ones. As you may see, microstates A and B correspond to the auditory and visual networks respectively, and these are sensory-driven microstates. On the other hand, microstate C corresponds to the posterior default mode network, and it plays a role in self-reflection, internal thinking, and memory, and it is a microstate that reflects higher order cognitive processing. Finally, microstate F corresponds to the salience network, which is crucial for detecting and integrating behaviorally relevant information. So as a result, throughout our longitudinal study, we endeavored to explore EEG microstates as biomarkers of cognitive impairment in multiple sclerosis and to evaluate the efficacy of the MIA cognitive training program through assessments of cognitive performance and alterations in EEG microstate dynamics before and after the intervention. Of course, to perform the home-based cognitive training, our patients were instructed to download the MIA application, as you may see here, on their electronic devices in order to engage with cognitive exercising that would hopefully improve cognitive functions. So our study included 30 patients, prevalently females, with a mean age of around 50 years and mild disease severity. The inclusion and exclusion criteria are shown on the slide, but what is important to note is that patients were included in our study if they exhibited cognitive deficit in at least one of the cognitive domains. Assessments were carried out at baseline, after 6 months of cognitive rehabilitation, and after 12 months of cognitive rehabilitation, and they included the EDSS, which is the Expanded Disability Status Scale that is the most commonly used scale for assessing disability progression in multiple sclerosis, standardized neuropsychological testing that is developed specifically for MS patients, and a 5-minute resting state EEG recording for our microstate analysis. Of course, throughout the study, our patients were instructed to complete the home-based cognitive training for around 20 minutes a day, 5 days a week. So here are our results at baseline, so before the cognitive rehabilitation. The heat map on the left shows Spearman correlations between EEG microstate features, specifically mean duration and global field power, and performance on various standardized neuropsychological tests. The analysis exhibited that longer duration and increased global field power of microstates A, B, and F were significantly correlated with worse cognitive performance, as for instance in 2 neuropsychological tests that are the PASAT 2 and 3 that evaluate information processing speed, sustained attention, and working memory. These associations were further reinforced by the linear regression analysis that you see on the right, which again exhibit that longer-lasting microstates A, B, and F are significantly associated with worse cognitive performance. Overall, at baseline, these findings may indicate that there might have been a predominance of sensory-driven network activity and impaired network switching flexibility, which is in line with what is also seen in literature in terms of cognitive rigidity in patients with multiple sclerosis. Moving on, these are our results after 6 months of cognitive training. And from a cognitive standpoint, you may see the graph on the left showing a positive trend of cognitive improvement across all the different neuropsychological tests, but only the PASAT 2 exhibited a statistically significant improvement from baseline to T1. These improvements occurred in parallel with changes in EEG microstate dynamics, as you may see on the right. So the top graph exhibits microstate C, which I remind you is a higher order microstate, and it exhibits that the mean duration of microstate C there was a statistically increased mean duration of microstate C from baseline to T1, which is a finding that could reflect a rebalancing of microstate dynamics post-intervention. Next, the graph on the lower right further shows that global field power increased significantly across all microstates after rehabilitation, which could suggest enhanced strength of microstate-associated network activity following the MIA training program. Since this is an ongoing study, so far only 15 of our patients have completed the follow-up at 12 months. So the results that you see here, both neuropsychological and neurophysiological, are very preliminary, and they're not statistically significant, but what is important to note is that they are in line with what we had also obtained at T1. Of course, our study did have some limitations. For instance, there was variable engagement with this home-based cognitive training. Certainly, absence of a control group and absence of patient-reported outcomes. But overall, we can say that the findings of our study are promising so far, since the MIA cognitive training was associated with better cognitive performance on the neuropsychological tests, alongside neurophysiological changes that may reflect adaptive reorganization of brain networks and potentially related neuroplasticity mechanisms. So we highlight the value of integrating EEG measures and standardized neuropsychological tests for the monitoring of our patients in our clinics. Thank you so much for your attention.
Thank you, Anastasia. Although it's very preliminary, this study is extremely interesting. I have just a couple of questions, from a pathologist, so be patient. First of all, I noticed that there is an extreme variability. Probably this is apart from the small number of subjects that you examined so far, but there is a kind of extreme variability. Does it depend on the type of test because you mentioned that there was the patient were not so much probably confident with the test itself, or is because you are looking at these variables which are not exact variables?
Of course, the relationship is not monotonous, and I think that it could have played a role, the fact that there was variable also engagement with the home-based cognitive training. There also, in terms of adherence, we knew that our patients, by the end of each month, they had to send reports through the application in order to show what type of cognitive training they engaged to, the level of difficulty they achieved, and the amount of time that they spent on the cognitive training. But this was, of course, variable amongst all of our patients. So this, plus the adherence, plus any sort of disease-related progression could have influenced the results. So.
You definitely need a larger number.
A larger number.
Extremely promising. Thank you.
Thank you so much.
The next candidate is Carlo Chikaron. She did her thesis work with a good friend of mine, Professor Andrea Polistena. Is not a teacher of our medicine course, but I know him very well because he's a very skilled surgeon, breast surgeon. And I'm asking you to present her work.
Absolutely. Good morning, members of the Commission, ladies and gentlemen. It is a pleasure to introduce Carlotta. She will defend her thesis on breast reconstruction after mastectomy, focusing on post-surgical outcomes and complications, comparing two different surgical approaches, with the aim of contributing to the ongoing evolution of breast reconstruction after breast cancer surgery. I invite Carlotta to begin her presentation. Thank you.
Okay. Good morning, everyone. First of all, I want to thank my advisor, Professor Polistena, of course, Professor Damari, and all professor here present. Cosa? Devo... Ok, scusate. Questo? No. Okay, sorry. Okay, my thesis focuses on postoperative complication in prepectoral versus subpectoral breast reconstruction after mastectomy. I'm going to start with a brief introduction about the role of surgery and reconstruction in breast cancer. Unfortunately, breast cancer is the most commonly diagnosed malignancy among women worldwide, and it remains a major public health challenge. And surgery has historically represented the cornerstone of breast cancer treatment. For many decades, the standard surgical approach was ousted radical mastectomy, an extensive procedure procedure involving removal of entire breast, pectoral muscle, and axillary lymph node. Although effective from an oncological perspective, it was associated with functional and aesthetic morbidity, so subsequently, less extensive procedures were progressively introduced, including modified radical mastectomy and total mastectomy, providing equivalent oncological outcomes while reducing morbidity. Then advances in breast cancer treatment led to the development of breast-conserving surgery that is currently preferred whenever oncological feasible. But at the same time, modern mastectomy techniques have evolved toward more conservative approaches, including skin sparing, nipple sparing, and skin-reducing mastectomy. This procedure preserve the breast envelope and facilitate an immediate breast reconstruction. So breast reconstruction has become an integral component of modern breast cancer treatment, with main goal being restoration of breast shape and contour, improvement of aesthetic outcomes, and enhancement of quality of life of patients. Breast reconstruction can be performed using either autologous tissue or implant-based technique. And while autologous reconstruction is still an optimal option in selected patients, implant-based breast reconstruction is currently the most widely adopted reconstructive strategy. And among implant-based technique, reconstruction can be performed using either the prepectoral or the subpectoral plane. Subpectoral reconstruction is historically considered the standard approach, and here the implant is placed beneath the pectoralis major muscle, providing additional soft tissue coverage. However, the muscle elevation is associated with increased postoperative pain, functional discomfort, and an animation deformity. So for this reason, and thanks to advances in surgical techniques, improvement of mastectomy flap quality, and the introduction of cellular dermal matrices, prepectoral reconstruction has experienced a renewed interest in the recent years. Prepectoral reconstruction is performed by placing the implant above the pectoralis major muscle, avoiding muscle dissection, and so potentially overcoming some limitation of subpectoral reconstruction, in particular animation deformity and muscle-related morbidity. Despite the growing popularity of prepectoral reconstruction, evidence remains inconclusive, and no clear consensus currently exists regarding the optimal plane position. So my thesis primary objective was to compare the distribution and pattern of postoperative complication between prepectoral and subpectoral implant-based breast reconstruction, and as secondary objective, we also evaluated the association with clinical, oncological, and surgical variables. So the study population included 103 implant-based breast reconstruction that developed at least one postoperative complication during follow-up, and it is important to highlight that only implant-based breast reconstruction that developed complication were included, so why we did not analyze the incidence of complication, but rather the distribution and pattern. So a total of 51 procedures underwent a prepectoral reconstruction, while 52 subpectoral reconstruction. This retrospective observational study was conducted at Policlinico Umberto I through the collaboration of breast surgery unit and plastic and reconstructive surgery unit. And the study population included implant-based breast reconstruction performed between 2016 and 2025. Data were collected from electronic and medical record and also from follow-up documentation to obtain a complete history of this patient. So before comparing postoperative complication, we compared the baseline characteristic of this patient that were highly comparable at baseline, with no statistical difference found in age, molecular subtype, comorbidity, smoking, and alcohol status. The only statistical difference found was the BMI that was higher in the prepectoral group, and one possible explanation is that prepectoral reconstruction has historically been considered more suitable in patients with thicker and better vascularized mastectomy flap. Then, about postoperative complication, a total of 112 complications were recorded, with the most common one being capsular contraction, and this is in agreement with current literature that recognizes capsular contraction as one of the most relevant complications in implant-based breast reconstruction. It was also found that 69.9% of procedures required at least one additional treatment or intervention, with the most common one being lipofilling and implant replacement, for a total of 129 treatment or intervention recorded. So this finding highlight has postoperative complication may require further treatment over time and may have an impact on the reconstructive pathway. Then about the comparison of individual complication, we found out that the only complication significantly associated with the implant position was animation deformity, affecting 15.4% of procedure only in the subpectoral group. And this is consistent with literature that recognizes animation deformity as one of the principal drawbacks of subpectoral reconstruction, and one of the reasons why prepectoral reconstruction has gained increased popularity in the recent years. Then we explored factors associated with complication. First, BMI. And higher BMI was significantly associated with higher risk of infection. And this is also in agreement with literature that recognizes obesity as a risk factor for infectious complication. But interestingly, in the prepectoral plane, we found out a baseline and higher BMI, but despite this difference, we did not observe any overall higher complication rate in the prepectoral reconstruction. And one reason may be that patient-related factor as BMI may play a more important role rather than implant position itself in determining complication. About the two-stage reconstruction, also a significant association was found with seroma and infection. A possible explanation is that in tissue expander-based breast reconstruction, may be associated with a longer reconstructive pathway, the prolonged device exposure, and also additional tissue manipulation, all of which may contribute to this complication. About type of mastectomy, nipple sparing was significantly associated with seroma and implant displacement, while skin reducing was significantly associated with infection. So complications appear to be multifactorial and influenced by patient, surgical, and reconstructive related factor. In conclusion, so prepectoral and subpectoral implant-based breast reconstruction show overall comparable postoperative complication profile, with all the complications significantly associated with implant position being animation deformity. So complication again appear to be multifactorial, and these findings support an individualized selection of patient rather than a universal preference for either reconstructive plane. Obviously, future prospective studies, including both complicated and uncomplicated reconstruction, are needed to further clarify the role of implant position and also of other clinical variables in postoperative outcomes. Thank you so much for your attention.
Thank you. It was very nice and very well presented. I see Dr. Sorotos, but I don't know if you have time to listen to her presentation, is because you know, she was dealing with complication after prepectoral and
only the last half.
okay.
So I'm sorry, I cannot ask anything.
Anyways, BMI is related probably to diabetes, or because I mean, more infection, I think, means that
Yes, about comorbidity, we want to analyze the diabetes, but unfortunately we didn't have enough data, because obviously we know that diabetes may be correlated to the risk of infections, to the delay in impairing wound healing. So maybe in future studies, they may focus more on this comorbidity.
What about contracture? Does it depend on surgery or follow-up? Because I remember that, you know,
contraction.
You have to be very careful with your patient, explaining her what she has to do and she doesn't have to do to avoid contraction, or no?
Basically, animation deformity is more related to the contraction of pectoralis major muscle, because the implant is partially covered by the pectoralis major muscle. About contracture may be more related to the radiotherapy, to the infection, also to inflammation or hematoma, but I would not.
It's not always strictly dependent on the surgeon. It can be.
It can be related, yeah, to other factors.
Okay, thank you very much.
Thank you so much.
Okay, the next two candidates will be introduced by Professor Ferdinando Nicoletti.
Hi, Julia. Can you hear me?
Yes, we can hear you perfectly.
Okay, great. Okay.
So let me call the first one is Umay Kasando. Ferdinando, stage is yours. It's yours. Bye.
Okay, perfect. I'm really, first of all, good morning to everybody. I apologize if I'm not there with you, but I'm in a place in Sicily in front of Aeoli Islands for a meeting. So I'm out of Rome, so sorry for that. Nevertheless, I'm really delighted to introduce Umay. Umay is a very bright and very talented student. She carried out the project in Neuromed Institute in Pozzilli. Neuromed is a neuroscience institute convention with Sapienza University. And the topic of the thesis is interesting. It's on a new potential strategy for stress-related disorders based on mitochondrial quality control. And actually, the model that has been used for the thesis, which is a model of perinatal stress, has been developed by Professor Stefania Maccari, who is there with you in the committee. And so all the study was done in tight collaboration with Stefania Maccari. And I will be delighted if Stefania can say something on the candidate and on the student as well.
Thank you, Stefania. She's one of our excellent team in Course F. So
Yes.
I welcome you here. Please go ahead.
So thank you so much. Good morning to everybody. I am very happy to present the Umay Kasando today. She presented a preclinical study. This is very important because we can understand better the mechanism, and in particular, she used perinatal stress animal model that is well established model of vulnerability to stress-related disorders. It consists to stress the mother during the late gestation and reduce the maternal care and induce long-term consequence in the offspring during adult aging, but also in the second generation. Okay? So we, over the past decades, we used these animal models to understand better this long-term effect, epigenetic long-term effect of this early stress that today she showed an example of this early stress. Thank you so much.
Thank you. Please go ahead.
Good morning, everyone. Today I will be presenting mitochondrial quality control in a preclinical model of stress-related disorders. First of all, mitochondria originates 1.5 billion years ago when an ancestral eukaryotic cell incorporates an aerobic bacterium. In this way, now we can actually do an effective ATP production. Mitochondria is mostly famous by its oxidative phosphorylation, but it has a lot of qualities actually. It is crucial for iron, copper metabolism, for beta oxidation, etc. But the hindsight of these events, there will be reactive oxygen species production, and if the pores within the internal or external membrane are open, it can cause either apoptosis or it can trigger innate immunity. So that's why mitochondria is at the crossroad between the cell death and inflammatory signaling. Obviously, to prevent this, we have developed mitochondrial quality control in our cells. It's intricate pathways, basically, that monitors, replaces, or repairs mitochondria. For removal, we have mitophagy, which is a kind of autophagy. There is fission, fusion, etc. But maybe the most important and the most complicated one is mitochondrial biogenesis, because there are a lot of enzymes, there are a lot of proteins, and it leads to duplication of the mitochondrial DNA and genesis of new mitochondria. So we have observed that abnormalities in mitochondrial quality control in neurodegenerative disorders has been well studied, but there were no studies in stress-related disorders. So that's why we did this study, actually. Our aim of the study was to examine whether perinatal stress causes changes in the levels of mitochondrial proteins in the PFC and hippocampus, and to evaluate whether treatment with drugs that enhance mitochondrial biogenesis rescues the behavioral phenotype induced by PRS. To answer these questions, we exert restraint stress to pregnant moms for 3 times a day for 45 minutes, and we observed that there's a decreased maternal behavior. And also we have seen that in adult offspring, they have some behavior abnormalities. To understand what went wrong in the mitochondrial biogenesis, we obtained Western blot analysis, which contains one of the most important proteins involved, PGC1 alpha, NRF1, NRF2, etc. And for the treatment, postnatal adult offsprings has been administered methylphenolate, PQQ, or omaveloxolone, and PQQ. So, before jumping to our findings, I would like to give you a little bit of a detail about the mitochondrial biogenesis. Basically, PGC1 alpha is the master regulator of all these events. So, if PGC1 alpha activates NRF1, which is a transcription factor, there will be duplication of the mitochondrial DNA and mitochondrial proliferation. Here, also NRF2 is very important because it has antioxidative effect, which will protect our mitochondria from reactive oxygen species. So, we have observed that PRS causes a trend to reduction in PGC1 alpha levels in the prefrontal cortex of male mice. Prefrontal cortex here is important because it controls basically emotional regulation, social behaviors. Observing this PGC1 alpha level reduction in PFC was very important. Then we also have observed that NRF1 levels in the male PFC and hippocampus of male mice. Hippocampus is also very important for learning memory and stress responses. But last but not least, PRS reduces NRF2 levels in the PFC of male mice and enhances NRF2 levels in the hippocampus of male mice. So here we can actually observe a sex-dependent effect. For the treatments, we already used drugs that are in the market. For example, PQQ, here used for PCG1 alpha enhancer, but it's also used for glaucoma. And we pair this with either omaveloxolone or dimethylfumarate, which are both NRF2 activators. For example, again, omaveloxolone is used in Friedreich ataxia, and dimethylfumarate is an important factor in multiple sclerosis. So we observed that treatment with drugs that enhance mitochondrial biogenesis actually corrects PRS-induced deficit in social interaction in both males and females. So as our conclusions, we measured the levels of proteins involved in mitochondrial quality control and respiratory chain in mice subjected to perinatal stress. We have found that gender and brain region-dependent changes in proteins involved in mitochondrial biogenesis, and also we have found out that drugs that are known to enhance mitochondrial biogenesis, PQQ plus dimethylfumarate or PQQ plus omaveloxolone, administered in the adult offspring rescued the defect in social interaction induced by PRS. As the professors have stated, these findings raise an interesting possibility that alterations in mitochondrial quality control and they contribute mitochondrial function and new putative targets for therapeutic intervention. Thank you.
Thank you for this very interesting study, very well presented. There is a question from Professor Palange, but you have to come here because the microphone is here.
May I ask you, how do you quantify or let's say standardize perinatal stress?
This is a really good question, actually. What we can do is regulate a set, regulate a bar. We said, okay, our breast training, our PRS will be 3 times a day for 45 minutes, and we will observe what's going on. How we did it was actually very important because we put the pregnant dames in a very little plexiglass that they can't actually move, and there's a direct sunlight is coming to them. So there is really stressful environment for these dames. That's why, like, we set the bar saying, okay, this will be our quantification, and according to this stress that we have caused to these dames, we said, okay, these are our effects. Obviously, we had controls, and for the treatments, we had used vesicles, which are drugs, but they don't contain any active ingredients. So we have controls, normal mice, we have the ones that exposed to stress that we set, obviously, in our laboratory, and that's it. You're welcome.
Very short question for a very short answer from Professor Coletti.
Well, then I have to choose which one, because it was very stimulating. I would say, actually, if you know that if exercise which regulates GC1 alpha could be used as an approach to...
Actually, this is really interesting because, yeah, maybe it can regulate serotonin and dopamine pathways, and there will be a positive effect, of course. But here we just use the drugs that are already in the market for different things and known for mitochondrial biogenesis. But I believe that if there was research like this, it would be really interesting. Thank you, Professor.
Next candidate with Professor Nicoletti and Professor Vakari is Farah Tarek Mohamed Ahmed Hassem. She did a thesis on repositioning vortioxetine for the treatment of malignant gliomas. Please, Ferdinando, would you say a few words?
Yes, definitely I would love. Can you hear me again?
Just a moment. I asked, please, in the very beginning, I asked not to go back and forward. Okay, if I can, okay, we will stop until everybody is sitting, and non fare, guarda, o li fa entrare tutti subito o non li fa entrare più. I did ask people to stay. Air conditioning is on. Okay, bye Ferdinando.
Okay, I can go. Again, I love to introduce Farah. Farah is also a very, very intelligent student and also a lovely person. She attended all the lessons of pharmacology, and she was very active in answering questions, in contributing to discussion. So I'm very pleased to see Farah there. And again, I'm sorry not to be there with Farah. Farah work again at Neuromed Institute. The topic is a hot topic today, and is the novel treatment for malignant brain cancers, particularly glioblastoma multiforme, which is the most dangerous and aggressive brain tumor that we have. And actually, there are many drugs under development, but there is one drug that is an antidepressant and can be repositioned for the treatment of gliomas. And this is vortioxetine. And Farah will explain why, and she will present data obtained in cancer cells under the tutorship of Professor Antonella Arcella. Professor Antonella Arcella, she's a neuromed. She has been working for many years with Professor Felice Giangaspero, who unfortunately is no longer with us, and this is bad. So it will be a great honor and pleasure to listen to Farah.
I would like to thank Professor Nicoletti for the heartfelt introduction, and of course my thanks to the committee and the Institute for organizing this beautiful day. Okay, so my thesis is going to be on the repositioning of vortioxetine for the treatment of malignant gliomas. Glioblastoma multiforme is classified by the WHO as a grade 4 neoplasm with incidence ranging between 3 to 5 per 100,000 cases, slight male predominance, and like most neoplasms, a predilection for the older age. Molecularly, we have a very heterogeneous profile, but we most commonly see IDH and H3 wild-type phenotype, PI3K pathway mutations, and EGFR mutations. Histologically, also a very wide and heterogeneous profile. We see palisading necrosis most commonly, microvascular proliferation, amongst other cellular ATPia markers. The standard of care is maximal safe resection, followed by radiotherapy at 60 grays, fractionated over 2 grays per session over 6 weeks. And chemotherapeutic agents are temozolomide. So our justification for this study is a 2024 study published in the Nature Medicine journal called the High Therapeutic Identification of Repurposable for Antiglioblastoma Activity. So this was one of the most pivotal studies in the identification of specifically vortioxetine's potential for use in an oncological context. Vortioxetine itself is a multimodal antidepressant with, so it acts on several serotonin receptors. It fully agonizes the 5-HT1A receptor, partially agonizes the HT1B receptor, and antagonizes the HT1D, 7, and SERT, and the SERT, or the serotonin reuptake transporter. The aim of our study was to refine the knowledge of vortioxetine targets in glioblastoma multiforme, as well as to expand a little bit on the effect of different vortioxetine concentrations in glioblastoma cell lines. We started by doing a computational analysis of 2 RNA sequence databases, which had the genome sequenced of a lot of glioblastoma multiforme surgical specimens. Based on that, we did a survival analysis or a Mantel-Cox of the individual serotonin gene receptor expression in relation to patient prognosis, of course, to identify how canonical each receptor is in the prognosis of GBM patients. Then, in our own cell lines, which we obtained from surgical specimens in the NeuroMed Institute, of course, after obtaining informed consent from patients, we did a PCR evaluation for, as an indirect proxy or a satellite to understand which genes are the most expressed in different GBM cell lines. Then finally, we treated our specimens with vortioxetine, duloxetine, fluoxetine, all of which are antidepressants. And then finally, with an HT1B receptor antagonist. Of course, all of these are triplicated and done with varying concentrations. Then we plotted graphs for the proliferation of the cells according to the concentration over time.
and we detected apoptosis. So our cell lines are described here, as you can all see. The one thing, the three factors that they technically all have in common are going to be, of course, the GBM diagnosis, the Vimentin positivity, and then the IDH1 wild-type phenotype status, which we said before is one of the hallmarks molecularly. So vortioxetine showed a consistent and concentration-dependent antiproliferative action in all of our cell lines. Most importantly, at 20 micromoles, we saw a complete abolition of cell growth, which could be, yes, linked to the vortioxetine itself, but it could also be because of the toxicity at high levels of vortioxetine. Then vortioxetine mapped against other antidepressants showed a statistically significant superiority in vitro. And then for our PCR analysis, these are the dishes that we had, the slides. Then from this, we derive the table that you can see on the right, which shows that all of our cell lines express the HT1B receptor, and none of them express the HT3A receptor. Based on that, to make sure that the effect of vortioxetine is mediated by serotonin receptor 5-HT1B activation, mainly at least, we also did, as you can see on the left, an administration of vortioxetine at varying concentrations, a combination of vortioxetine and its antagonist, the antagonist on its own, and then the control, of course. Our study showed that vortioxetine definitely has oncologically relevant targets because we saw that in the RNA data sets that we analyzed. Then the effect is definitely concentration dependent, with high doses inducing oxidative stress, and then even higher doses being completely abolishing cell growth, as we saw. Vortioxetine acts by serotonin receptor activation, as demonstrated by our antagonist use. Then that vortioxetine is superior to other antidepressants, and most importantly, this study was done in vitro, so one of its most important limitations is the fact that we cannot really see whether it's actually possible to reach a therapeutic threshold of vortioxetine concentration in the CNS. So further studies are needed in vitro in select patients, in select patients to see how this projects actually on the GBM prognosis realistically. Thank you for your attention.
Professor Fabbrini has a question for you.
Yes.
Thank you very much. It's a fascinating topic, of course, because the antidepressant is widely used in clinical practice. My question is, based on your data, what would you think would be the dose that we should use in humans to reach target like the one you showed? Is there any idea? Because if a trial needs to be designed, we should know how much of the drug we can use.
So that's a very good question. I think it's important to underscore the fact that these are in vitro studies. This study specifically was an in vitro study, and that future studies should be done to identify whether or not there are individual factors that may affect the effective vortioxetine concentration inside the CNS itself. There's also a very important point, which is the fact that vortioxetine in general, of course, still depends, even if it penetrates the blood-brain barrier, still depends greatly on the vasculature, which is greatly altered. In fact, as we said before, one of the most important histological identifiers is microvascular proliferation in glioblastoma multiforme patients, which can affect the ability of the antidepressant or whatever therapy we're using to reach its target in the brain. In fact, that's also one of the reasons why temozolomide has a limited effectiveness, and recurrence is almost always guaranteed. The vascularity is not very reliable. Put in simple words.
Thank you. Now we have a slight change to the program. Elisabetta Rossi, because Professor Chiaretti has to leave. Elisabetta Rossi did her thesis work under the supervision of Professor Chiaretti, and she's going to introduce her work.
Thank you, Giulia. So Elisabetta did a thesis on a very specific argument that is not so common, because she worked on mastocytosis, which is a very rare disease and is often misdiagnosed. So she will present the findings from a cohort of patients from Sapienza University that were followed in the Centro Omartiorare. It's a pleasure for me to introduce Elisabetta, also because she just had a baby, and she was so good to keep on doing everything. So, Elisabetta.
Thank you, Professor, for your introduction, and thank you to the President and all the members of the committees. So my thesis is titled Indolent Systemic Mastocytosis, Clinical Features and Disease Evolution in a Monocentric Cohort of Adult Patients. So what is mastocytosis? Mastocytosis is a rare myeloid neoplasm characterized by clonal expansion of mast cells in different organs. As you can see from the image, there are three main big groups: cutaneous mastocytosis, where the disease affects only the skin; systemic mastocytosis, which is the one I'm focusing on; and mast cell sarcoma, which is a very rare solid tumor. Adults are primarily affected by systemic mastocytosis, and as you can see here, there are different subtypes with different degrees of aggressiveness. The indolent systemic mastocytosis is the most common form, and is also the least aggressive subtype. So patients have a very favorable prognosis and a normal life expectancies. However, they suffer from different clinical manifestations that affect multiple organ systems that can quite impact profoundly their quality of life. They suffer from GI tract manifestations such as diarrhea, abdominal cramps, vomiting. They have recurrent pruritus and flushing and maculopapular lesions. They suffer from precocious osteoporosis and osteopenia, but also they can suffer from neuropsychiatric symptoms such as brain fog, cognitive difficulties, headache, depression, chronic fatigue. They have recurrent anaphylaxis episodes. They can suffer from palpitation, dizziness, and have organ involvement. So while this is the most common form of systemic mastocytosis, there are only a few studies that actually focus specifically on this indolent form, and that's why experts have highlighted the need for a better characterization of the symptomatology and possibly identification of prognostic factors that determine which are the patients that are more likely to experience severe manifestations. So the objective of our studies was to identify what are the clinical manifestations patients present with at the disease onset, what are the signs and symptoms they develop along the course of the disease, and also whether if the signs and symptoms actually correlate with serum tryptase levels, which is a biological marker measured in this disease, and bone marrow histology, which is necessary for the diagnosis. So we conducted a retrospective observational studies analyzing the historical data from 52 patients that are followed at Centro Malattie Ematologiche here in Policlinico Umberto I, and we collected demographics, so sex, age of diagnosis, obviously clinical features at disease onset and along the course of the disease, the serum tryptase levels, bone marrow histology, the presence of this mutation which is called KIT D816B, which is present in the vast majority of patients, and which symptomatic treatment they received. And also we try to assess whether if there was a correlation between the percentage of bone marrow mast cells and serum tryptase levels, if the symptoms burden correlated with serum tryptase levels, if symptoms burden correlated with the mast cells percentage in the bone marrow, and also if this percentage of mast cells in the bone marrow correlated with the bone status, normal osteopenic or osteoporosis. These are our results. In our sample, there was a female predominance and the median age of diagnosis of 54, whereas from this pie chart, you can see that at onset, patient presented, the vast majority presented with urticaria pigmentosa, which is the name given to the maculopapular lesions that are typical of this disease, but also they presented with unexplained anaphylaxis episodes, preconscious osteoporosis, and also gastrointestinal symptoms. Whereas along the disease, majority of them suffered from gastrointestinal manifestation as well as neuropsychiatric symptoms, cutaneous symptoms, urticaria pigmentosa if they didn't develop it at onset, and also recurrent anaphylaxis and organ involvement. As for the correlations, we found a positive, significant correlation between the serum tryptase levels and the percentage of bone marrow mast cells. However, neither of these two variables correlated with symptoms burden, and also we didn't find a significant correlation between the bone marrow mast cells percentage and the bone status. If anything, our non-significant association had a negative trend. So the clinical characterization of our cohort actually aligns with current literature, as well as it was reported already that the percentage of bone marrow mast cells correlate with serum tryptase levels, and also it was reported that these biological markers do not correlate with clinical findings. And there was previous studies that actually found an inverse relationship between the percentage of bone marrow mast cells and osteoporosis. So even though what we found was non-significant, the fact that it had a negative direction somehow is corroborated by the study. And to conclude, so while being the most common form of systemic mastocytosis, the indolent form is still underrepresented in research. With our studies, we characterize patient signs and symptoms from onset, revealing a correlation between bone marrow histology and serum tryptase levels, but not with clinical findings. Hopefully, future research with larger sample and multi-center cohorts will characterize even better the true patterns of signs and symptoms in this disease. And I want to end by thanking again my supervisor and my co-supervisor and all of you for the attention.
Thank you, Elisabetta, for this very nice work and very well presented. Marcella, Ilaria, do you have, Ilaria has a question. Professor De Giudice.
Thank you for the topic, very interesting. Given the polymorphism in clinical manifestation, I was wondering if these patients arrive at the final diagnosis with a delay.
Yeah, absolutely, especially if they seek help from specialists that are not hematologists or allergologists. These patients have a diagnostic delay. In literature, is reported between 5 and 7 years. In our samples, we had 3 to 4 years of diagnostic delay because it's a rare disease, and definitely you have to think about it before actually measuring the serum tryptase levels or perform a histology.
Thank you. The next candidate is Nadab Roa. He did his thesis work under the supervision of one of our professors from Sant'Andrea Hospital, Professor Michael Sorotos, who's going to introduce his thesis.
Hello, good morning everybody. I'm very, very happy to present Nadab. He's been an excellent student and also, I would say, a friend for me. I'm actually going to miss him. He's going to present a study that we did together regarding the screening we offer our patients before microsurgical breast reconstruction. This is a unique protocol that we use in our hospital to evaluate our patients and decide what kind of reconstruction they're going to get. Good luck.
Thank you. Hello everyone, how are you? Okay, so the topic of my thesis is about the role of genetic screening for thrombophilia on the surgical planning of breast reconstruction, and I first want to thank my supervisor, Professor Sorotos, for his guidance throughout this project. So a bit of background, microsurgical breast reconstruction, such as the DF flap shown here in the illustration, mainly depends on vascular patency. Flap thrombosis is not a very common event. The rate is between 1 to 5%. However, in this world, in real life, we do these procedures a lot, so this could translate to many patients, and this could lead to either a complete or a partial flap loss with severe consequences. So we aim to prevent it as much as we can, obviously. Performing thrombophilia genetic testing was suggested a few years ago after an interesting case of bilateral DF flap thrombosis in a patient in Santa Rosa Hospital, which is very uncommon. She went on to perform later on the genetic panel, and she was shown positive for several variants for thrombophilia, increasing her risk for thrombosis. So this type of screening was incorporated into the perioperative assessment. And also the clinical utility of such screening remains unclear because of a low amount of research on the topic. So the aim was to evaluate first the prevalence of thrombophilia-related genetic variants and to assess their potential impact on the surgical planning in selected patients undergoing breast reconstruction. When we say selected patients, we focused on a population which is of high clinical risk for venous thromboembolism that was assessed through the modified Caprini assessment score, shown also here, that includes several risk factors. This is usually used for initiation of thrombophylaxis for surgical candidates, but we also use it to determine whether patients will undergo the genetic panel based on their risk. And the hypothesis is that in those patients with high risk and high score, so breast reconstruction patients selected for preoperative thrombophilia testing due to increased thrombotic risk, the presence and burden of thrombophilia-related genetic variants is associated with modifications of their surgical plan. The study is a retrospective observational single-center study with 39 patients. All of them were included in the first analysis of the prevalence of the variants. 9 were excluded from the subsequent analysis of the association between the variant burden and the modification of the surgical plan. This is because they had a primary indication for implant-based reconstruction, and we're looking for autologous-based to implant-based change from either DF flap or latissimus dorsi flap. For patient selections, first eligibility for autologous breast reconstruction was needed. Then, as I mentioned before, the patient clinical thrombotic risk via the Caprini assessment was made, and those selected high-risk patients performed thrombophilia genetic testing. We used the Fisher exact test because of the small sample size with p-value of 0.05 for less than that for significance, and we stratified the patients into 2 groups based on their variant burden. A low burden was 0 to 3 variants, and a high burden of 4 or more variants. So the flow is that the autologous reconstruction candidates went on to perform the Caprini assessment, and those with high score, particularly those with personal or family history of venous thromboembolism or spontaneous recurrent abortions, went to perform the expanded thrombophilia genetic panel with several variants, as you can see here, regarding coagulation, fibrinolysis, platelet aggregation, and homocysteine metabolism. We evaluated both major thrombophilia mutations, such as factor V latent prothrombin GA that are highlighted here in red, and other thrombophilia-related polymorphisms. And then for each patient, we had an integrated reconstructive planning based on their genetic panel results and their preliminary clinical risk for thrombosis. If we look at the results, we have some basic demographics here on the left, but more importantly on the right, on the light blue area, 37 out of 39 patients, so about 95% showed at least 1 variant in their genetic panel. Most of them had 4 or more variants. Only 2 patients were completely wild type for all the variants that I mentioned before, all the genes. So this highlights the high prevalence in this high risk cohort. And it's important also to note the major thrombophilia mutation that I mentioned before were less uncommon. Only one patient was heterozygous for factor V Leiden, and all patients were wild type for prothrombin GA. However, the thrombophilia-related variants, the other ones were very frequent. If we look at the surgical plan modifications, so we started with 30 initial candidates. As I mentioned, 9 were excluded. 2 more were excluded as well because they had an autologous to a different autologous breast reconstruction chain, so from a DF flap to latissimus dorsi or vice versa, and we're looking for autologous to implant base. So out of the remaining 28, 7 had an autologous to implant base change, all of them in the high burden group. However, a statistical analysis did not demonstrate a significant association between variant burden and the modification of surgical plan. This mainly is attributed to the small sample size of only 28 patients. So how do we interpret this? Thrombophilia-related variants were highly prevalent in this high-risk cohort. The modification of planned autologous to implant-based reconstruction occurred only in the high-burden group, which was not statistically significant based on the small sample size because of that. And the main conclusion is that thrombophilia genetic screening may serve as an adjunctive tool for perioperative risk assessment in those selected high-risk patients rather than an independent determinant of reconstructive strategy. So when we plan reconstruction, we need to integrate both the patient's genetic profile and their broader clinical risk for thrombosis. And for the future, larger studies are obviously required. We should standardize the approach for panel interpretation and evaluate them based on specific variants and also variant combination risk models. And it's important also to assess the correlation of the actual thrombotic complications with the genetic test-guided reconstruction plan modifications in the future. Thank you very much for your attention.
Thank you, Nadab. This is a very interesting study, and you were very, very good in presenting it. Are there any questions? I have a small question for you. So this thing would extend potentially to all kind of surgeries in which you do a flap,
Yes.
like maxillofacial or
Exactly.
whatever. So you suggest this type of screening. Professor Della Monaca, do you do genetic screening for thrombophilic when you do flaps? Because you are, they do lots of flaps in their experience. Not usually.
Usually we relay mainly of the simple blood test and we collect the
Yeah. So
did you screen for the same mutations or in a patient without complications? Just to see, of course it has to be correlated, but you never know. You might.
No, we didn't look at the complications themselves. We mainly screened we wanted to see first if there was a significant association with the modification.
Okay,
yeah,
perfect.
Exactly. But for your question, potentially, yes, this is, as Professor Soroto said, they do it in Sant'Andrea particularly, but potentially this could be expanded to other centers and for any type of microsurgical reconstruction technique. Yeah.
Definitely. Thank you. Okay. The next candidate is Alessia Dto. Alessia. She did her work under the supervision of Professor Coletti, who is going to introduce her.
Sure, with pleasure. Alessia, I met Alessia as a first-year student, pretty much as every other student in this room. She appeared immediately as someone with a very, very smart and with a very particular, let's say, mind. She shows a real authentic interest for research and also a passion for internalization and traveling, She visited multiple laboratories during her career. She went to the University of Sao Paulo, University of Cologne, Sorbonne University, African Leadership University in Kigali, Korea. I don't have time to mention all of them. So I proposed her a project that required a vast international network that she managed to set up alone. So that was outstanding. And she did a massive amount of work that led to this thesis entitled Towards Personalized Medicine, a Bayesian approach to risk stratification and predictive modeling for cachectic cancer patients.
Good morning, everyone. Thank you, Professor. So let's dive in, cancer cachexia. So we are talking about a muscle wasting syndrome in cancer patients. So we have to keep in mind that these patients are characterized by weight loss, by systemic inflammation, and by other metabolic alterations. So the patient is facing a complete shift towards a catabolic state. The thing is that even with the nutritional support, the patient continues losing weight. So this is what makes cancer cachexia extremely interesting. The majority of cancer patients are affected by cancer cachexia, and it's a deadly condition. So we ask ourselves, is it possible to calculate the probability of having cancer cachexia given a specific patient with a specific level of one biomarker, with another level of another biomarker, and so on? Well, yes, it is. It is possible. We do have the mathematical tools to do that, but in order to apply our special mathematical formulas, we needed patients for our study. We gathered 21,000 patients. They come from 10 laboratories across 4 continents. So we actually started active collaborations with 10 universities around the world. They sent us their data sets, and we had the specific value of every specific biomarkers of every specific patient among these 21,000 patients. We ended up studying 5 tumor types and 45 variables and biomarkers. Hemoglobin is just one example. As you see here, we divided our patients into 2 groups, so the high parameter and low parameter. In this case, high and low hemoglobin. In order to calculate a cutoff, we utilized in the national consensus, or for some new biomarkers, utilize the median of healthy controls. So you may ask now, so which were the special formulas that you were using? Well, there are some formulas that have never been used before in medicine. In this field, they are part of Bayesian inference. Now, we have to make something clear. When we talk about probabilities, we have 2 main approaches: classical statistics and Bayesian inference. Classical statistics is like a snapshot of our probabilistic situation. So if we want to add new information to our study, we have to rerun our test and recalculate a p-value. In Bayesian inference, this doesn't happen. We have no p-value. We have a much more dynamical situation, just like a video in which we can add new information, we can add new data, and our system updates itself without recalculating anything, without rerunning any test. Now, this is the system that we chose for our study. As you can see, the Bayes theorem is about a posterior probability. So the probability of having cachexia of a specific patient with a specific level of a biomarker. And this posterior probability is based on new information that we are integrating into a prior probability. So to have an overview of that, here we have an example with hemoglobin again. So we have 2 prior probabilities, one for males and one for females. The first observation is that the probability of having cancer cachexia for males and for females seem to be different. And actually, this is something that in literature is still being discussed. And here instead with our framework, we are actually demonstrating that yes, there may be sex differences in cancer cachexia. And this can also help redirect therapies. Then we have 4 posterior probabilities that you can see represented in here. 2 for males, 2 for females, each one for high and low parameter, in this case hemoglobin. You see that the male prior probability updated with this new information that is high hemoglobin in this case, well, it changes. So the probability of having cancer cachexia changes, it gets updated. So we can say that a male with cachexia, so a male with cancer, if he has got high cachexia or high hemoglobin, or he has got a lower probability of having cancer cachexia. So in this case, high hemoglobin can be probabilistic protector, and low hemoglobin, so condition of anemia, in this case, can be a probabilistic risk enhancer modulator, because you see how much the probability gets higher. That's a fantastic tool, and also this is just an example for hemoglobin, and the role of hemoglobin has been extensively studied in literature. But imagine doing this with all of our variables that we studied. Imagine doing this for 85 times. So in our study, we did 85 graphs of like that and 85 rows of this table. Imagine 340 posterior probabilities following this Bayesian framework. So we also wanted to risk stratify our patients. So we did a heat map of all of our 85 cases and data sets. And as you see, females always tend to have lower probabilities. Green, yellow, they tend to be on the female side. We also wanted to compare different groups, and in order to do that, we utilize another Bayesian tool that we call the relative risk change, the RRC. So we compared variables among the same cancer types. In this case, colon cancer. And in a blink of an eye, you can see sex differences. So when the RRC goes in the opposite direction, this means that that parameter is behaving mechanistically differently in the two sexes. And then on the positive side, so above 0, you can see all the risk enhancers, and below 0, you can see all the probabilistic protecting modulators and the main ones. Among all the variables that we studied, we also wanted to have an overall view, and we did that by grouping biomarkers into 4 domains. We call them domains, so to genetic, hormonal, inflammatory, and metabolic. So to the question, which is the most influential domain? Which is the domain that has got the most risk enhancers? Well, in a glimpse, we can see it's the inflammatory one. And it's a great tool for researchers. It's like a biological compass that we can give researchers to help direct therapies and targeted therapy research. But do we have also another tool, not just for researchers, but also for clinicians? Can Bayes actually give a tool for clinicians? So imagine that we have one patient in front of us. He has got a particular level of one biomarker, another level of another biomarker. Can we actually tell him his probability of having cancer, cachexia? Well, yes, we can, and we can do it thanks to a sequential application of Bayes' theorem. As you see in here, a cohort of 3,000 patients with colon cancer, you see that the highest probability of having cachexia is represented by males with high platelets and low hemoglobin. That's just an example with just 2 variables, but imagine doing this with many, many more variables, with all the 45 variables that we study. And imagine doing this with even more. We can actually draw a biological identity card of that specific patient. So to conclude, we understand that the Bayes framework that we use is a good integration between computational medicine, mathematics, biology. It looks at the future unlike classical statistics. So we are actually creating personalized predictive models. It's a proof of principle for cancer cachexia, but it can be applied to all the pathological conditions that you can think about. And we actually are planning to do more future studies integrating this with machine learning and AI, and we are sure that these are the first steps towards personalized medicine and a revolution into personalized medicine. So thank you so much.
Thank you for this brilliant work and brilliant exposition of work. Professor De Giudice has a question for you.
If I understood correctly, most of these patients comes from China. So I was wondering if you applied this system to correct for ethnic-related variables that can affect the results, because, as you know, maybe we cannot translate directly these results in other populations with a different genetic background.
Thank you for your question. That's extremely interesting. And the aim of our study is also seeing ethnical differences between groups. The table that you were seeing before was just a differentiation for hemoglobin, so just one variable. For other variables, also we could say also the percentages of ethnic differences varies as well, but we do plan to compare ethnicities. And that's why we also enrolled patients. We made an effort to enroll patients from as many countries as we could, as many continents as we could, from Africa, South America, North America, Europe. So yes, our aim also for future studies is utilizing advanced Bayes tools, for example, the Bayes factor, to actually give significance to each one of these ethnic groups and understand how risk changes according to the ethnicity. So you highlighted a very important point. Thank you.
Thank you. Thank you very much. Okay. Our next candidate is Marco Martinelli. He did his work under the supervision of Professor Ilaria Del Giudice, who's going to present.
Thank you, President. Splenic marginal zone lymphoma belongs to the highly heterogeneous group of marginal zone lymphomas. And Marco Martinelli will present us a retrospective monocentric study on patients affected by this disease, focusing on the evolution of therapeutic approaches over the years, validating a new prognostic scores, and also giving some hints on similar lymphoma types that are named splenic lymphomas and have been recently reclassified in the last WHO classification. I'm very pleased to introduce Marco, that attended our outpatient clinics working with patients affected by this type of lymphomas and other lymphomas. So for me, it has been a real pleasure to follow him in this thesis work.
Thank you to Professor Del Giudice for the kind introduction. Thank you to the President and all the members of the committee. So splenic marginal zone lymphoma is a rare indolent splenic B-cell neoplasm, accounting for 1–2% of all non-Hodgkin lymphomas and 20% of marginal zone lymphoma. It originates from the spleen, where it invades the white pulp with a nodular pattern, and in virtually all the cases the bone marrow with a nodular or intrasinusoidal pattern, and very often the peripheral blood as well with bilious lymphocytes. It has an indolent course. Indeed, the 10-year overall survival is 70%. Usually patients are approached with a watch and wait strategy, but for those that are symptomatic, usually systemic therapy is administered either rituximab alone or coupled to bendamustine. For those patients that have a refractory symptomatic splenomegaly, splenectomy is performed, while BTK inhibitors are used in case of relapsed refractory disease. Antivirals are administered in case there is HCV infection driving the pathogenesis of the disease. And the latest WHO classification, that of 2022, two distinct entities have been identified: splenic diffuse red pulp small B-cell lymphoma and splenic B-cell lymphoma with prominent nucleoli. However, in the ICC classification of 2022, these two entities were grouped under the name of splenic B-cell lymphoma unclassifiable, underlying how at the moment there is no unequivocal definition of the disease. This monocentric retrospective study aims to describe the clinical features, the therapeutic options, and the outcomes in terms of progression-free survival and overall survival, to validate the marginal zone lymphoma international prognostic index score, and to compare the two new entities with the more common splenic marginal zone lymphoma. The population included in the study was represented by patients followed at the Institute of Hematology at Sapienza University of Rome with a diagnosis of either splenic marginal zone lymphoma, diffuse red pulp or prominent nucleoli entities from 2005 to 2025. Overall survival and progression-free survival have been calculated using the Kaplan-Meier method, and for each patient from the medical records, the demographic data, the laboratory exams, clinical features of presentation, therapeutic choices and response to therapy, as well the IPI prognostic score have been collected. So a final cohort of 105 adult patients was included, 54 males and 51 females, with a median age at diagnosis of 73 years. As you can see from the table, the splenic marginal zone lymphoma tend to present with low rate of base symptoms and cytopenias, while usually presents with splenomegaly, in contrast with the prominent nucleoli entity, which tend to present with higher rate of base symptoms and cytopenias. Watch and wait strategy was the first approach in 48% of patients, and at the end of the study, 14% of patients of the total cohort never required therapy. Splenectomy was performed in 21% of patients, while 64% of them received systemic therapy, again, mainly rituximab alone or coupled with bendamustine. Response to therapy was pretty good, since 62% of patients had a complete response, while 26% a partial response. Disease relapse was an event in 29% of patients out of the 90 treated patients, with a median time to relapse of 50 months. Histological transformation was an event in 4% of patients, and this is consistent with what we found in literature. After a median follow-up of 56.3 months, the 5-year and 10-year overall survival was 92.3% and 76.5% respectively, while the 5-year and 10-year progression-free survival was 73.8% and 43.3%. A brief focus on the two new entities. We can see that the 3 patients with diffuse red pulp all underwent splenectomy before being diagnosed with diffuse red pulp, possibly underlying how it's still difficult to differentiate diffuse red pulp with splenic marginal zone lymphoma, while the 5 patients with prominent nucleoli showed a high refractoriness, especially to chemotherapy, a more aggressive behavior for a general and more difficult management. We then calculated the IPI prognostic score for those 66 patients that received systemic therapy. This is based on 5 parameters: hemoglobin, LDH, lymphocytes, platelets, and nodal and/or disseminated subtype. So the patient was subdivided into low, intermediate, and high risk group based on the absence of those parameters, the presence of 1 or 2 parameters, or at least 3 parameters respectively. And as you can see from the table, the 5-year progression-free survival and overall survival of our cohort are consistent with that found in literature. So to conclude, splenic marginal zone lymphoma has an overall favorable prognosis, and this is consistent with literature. The validity of the IPI prognostic score is confirmed by results of our cohort, even though the results are not statistically significant, but this is due to the limited sample size. The prominent nucleoli seems to have a more aggressive behavior and should be promptly identified. And as a future perspective, there could be the integration of validated biomarkers into the clinical score and in general the routine clinical practice, as well as the use of BTK inhibitors, specifically in trials with prominent nucleoli entity and also splenic marginal zone lymphoma. Thank you for your attention.
Thank you, Marco, for this interesting study and very well presented. Are there any questions from the committee? I'm not an expert. Oh, bye. Yes, why not? Oh, you... No, ma Marcella. People who know me know that I'm afraid of hematopathology. I'm scared.
Thank you very much, very nice work. Just a very short question. When do you decide to perform splenectomy or systemic treatment?
Okay, so it depends on the decades we are speaking about, because in the past, especially in the first decade of our study, splenectomy was performed a lot, while with the arrival of systemic therapy, considering that splenectomy has a lot of risk, especially infectious risk and bleeding risk, systemic therapy has been preferred over splenectomy, especially in the last decade, given the high rate of effectiveness of rituximab and rituximab coupled to bendamustine. So at the moment, systemic therapy is preferred over splenectomy.
Would you like to? Please go ahead.
In terms of future perspective, we have seen that this prognostic score is based just on clinical parameters. So my question is what we know about the biology of splenic marginal zone lymphoma that maybe in the future can help us in refining the prognostic assessment.
Okay, so as you said, at the moment there are no biomarkers in the clinical score and the clinical routine clinical practice, but there is a recent study conducted by Bellinzona and published in the New England Journal of Medicine that revealed the presence of two clusters of genes, DMT and NKK, with NKK cluster of gene that has a lower survival rates. But at the moment, as I said, and as you said, there are no validated biomarkers that can be used in the clinical score.
Next candidate is Rafael Capidino. He did his thesis work under the supervision of Professor Giorgio Grani, an excellent teacher of our course. And please, if you can introduce his work.
I see that you are enthusiastic of Raffaele as much as I am. And I was just to underline that he performed this work for 3 years, and he was involved in both parts of this translational work. He was involved in the molecular biology part, and he has learned all the techniques needed for this work, and he was involved also in the clinical care and evaluation of our patients. Thank you, Raffaele.
Thank you so much for the introduction, and thank you to all professors and members of the committee and to everyone here. So my thesis project, as anticipated, regards the potential role of liquid biopsy in papillary throat cancer patients treated with lenvatinib. Less than 10% of PTC present with distant metastasis, and 2/3 of these patients present radioactive iodine refractory disease. For this reason, the overall 5-year survival of this very specific subset of patients is less than 50%. Those who present multiple lesions which are not treatable locally and a progressive disease are eligible to treatment with lenvatinib or other TKIs. These drugs carry significant adverse effects, and the disease may become resistant over time. For this reason, a very strict clinical follow-up is necessary with a thyroglobulin test performed every 3 months and CT scan every 3 to 12 months. Now, frequent CT scans expose patients to radiation, of course, and this is particularly relevant in our cohort in which we observe a rather long follow-up. On the other hand, thyroglobulin itself is not a validated biomarker to assess disease response in this setting, and in patients with anti-thyroglobulin antibodies or in whom thyroglobulin levels are too high to detect, it becomes completely uninformative. Our proposal, therefore, was to employ liquid biopsy, which is a non-invasive lab test performed on a sample of any body fluid to measure cancer biomarkers. Specifically, we measured freely circulating serum MIR146A5P and MIR2213P, because in 2 previous studies they were found to be associated to PTC as oncogenic microRNAs. Therefore, our aim was to assess whether MIRNA serum levels in PTC patients treated with lenvatinib associate with disease status, in the setting of a retrospective experimental analysis taking data from a larger prospective study. We used the CT scan as our reference, and CT scans were analyzed and the response to therapy was classified according to RECIST criteria version 1.1. We then calculated the sum of longest diameters of the lesion and used it as a surrogate estimate of tumor burden. Concomitantly with the CT scan, we collected the blood samples and we extracted microRNAs from the serum, synthesized complementary DNA, and performed digital PCR, which allows an absolute quantification in copies per microliter. We included 19 patients in total, which is we believe is a rather large sample considering the frequency of the condition. And in this waterfall plot, I represented the percent change in target lesion diameters at best response for each patient. We now moved to the heart of the study, which is the post-TKI MIR longitudinal trend analysis. In this plot, I represented the SLD, which is the sum of longest diameters of the lesion, and the microRNAs levels of a representative patient. So this is just one example. As you can see, at the same time of a decrease in the SLD, we observed an increase or stability in microRNA levels. At the third time point, the opposite occurred. So an increase in the SLD was correspondingly found with a decrease in both microRNAs. Considering our whole patient cohort, we observed this inverse relation in 79% of patients for the first microRNA and 74% for the other, independently of autoimmunity. Now, we have a problem. We need to find a cutoff to distinguish increase from decrease in target lesion sizes. We couldn't use absolute values due to the very high inter-individual variability of microRNAs. Therefore, we introduced the concept of fold change. Thereby, we expressed microRNA levels respectively to the previous highest value of MIRNAs. This is because, according to our trend analysis, the highest value corresponded to the maximal response. Therefore, we performed a ROC analysis to find a cutoff and to understand if we could use these biomarkers to distinguish increase from decrease in the SLD, and found an area under the curve of 76% for the first microRNA and 72% for the other. We then moved to another consideration, which is, can microRNAs predict response to lenvatinib, and do they associate with progression-free survival? To do so, we had to completely change the time points of our analysis. Therefore, we took blood samples respecting these temporal criteria, and surprisingly, we found that higher MIRNA ratio seemed to predict a shorter PFS, and shorter disease response to lenvatinib. This was statistically significant only for MIR146A5P. In conclusion, we can claim that freely circulating microRNAs seem to be potential biomarkers to monitor disease response to TKI treatment independently of autoimmunity, that an increase in microRNA levels might indicate disease response. Conversely, post to pre-TKI ratio could be a predictor of response to TKI, with specifically a higher MIR146A5P ratio seemingly associated with a shorter PFS. Of course, considering the very small sample size, we need to validate these results in an independent and larger patient cohort. Thank you very much for your attention.
Thank you, Raffaele, for this brilliant study, very well presented. Are there questions from the committee? Just a question. Which are the difficulties in performing this analysis? I mean, the rate of detection, is it easy to perform? Would you suggest could be available to a large use?
Thank you very much for this question. Of course, this is the crucial point. This is an exploratory study, so we tested whether there was indeed an association with the disease status in this very particular set of patients. Of course, there are not many patients, and as you can see, the biggest problem is, despite the rationale of digital PCR, which allows an absolute quantification, we cannot use absolute levels of microRNAs. We always need to compare to another point in the same patient. So this could be a limitation, could be something to account for, specifically the fact that we need at least 2 post-TKI blood samples. The other, let's say, potential problem would be the ZENT, so the mobile reference point, but this is something that actually we took from the RECIST criteria itself. Also in RECIST criteria there are mobile time points and reference points to understand progression and response. So we believe that these limitations need to be accounted for, but could be tested and validated in a larger patient cohort to understand if they are actually clinically applicable in the future.
I believe it, and as I always say, chi l'ha detto che non si può.
Thank you.
Next candidate is Elani Papari. She did her thesis under the supervision of Professor Stefano Gumina. Is an excellent teacher and also a great professionist, so I expect a very nice thesis. Please go ahead.
Thank you. Eleni was a very brilliant and smart student, and it's a pleasure for me to introduce her on this important day for her. So the use of e-scooter increased rapidly in our cities, and the low cost and the convenience for short distance travel made it very, very popular, above all among young people. And so we observed an increase in injury of all parts of our body, and all bones and all joints. And there is a mismatch between the popularity of these scooters and the adaptation of infrastructures and regulations. So she studied the incidence, the epidemiological characteristics and the clinical characteristics of e-scooter-related injuries. And above all, she focused her attention to the shoulder and elbow joints. And we hypothesized that the data that we observed may be completely different with respect other studies that were published recently, above all because of the infrastructures of our metropolis is completely different with respect to US cities or North Europe cities. Please.
Thank you so much, Professor. So I would like to thank Professor Gumina for giving me this opportunity to conduct the thesis at his department, as well as my correlatore Giovanni Longo for his huge help during the study. As my supervisor anticipated, my thesis title is E-Scooter Related Trauma in an Urban Tertiary Trauma Center. And we're gonna talk briefly today about the epidemiology as well as the subgroup analyses we performed on the shoulder and elbow fractures. Before starting, I would like to give a few background information. As you're probably all aware, e-scooters have rapidly increased in popularity and have managed to become one of the most widespread tools of urban micromobility worldwide. This can be reflected also in the graph you can see here, where we can appreciate an exponential increase in the number of shared e-scooter fleets in Italy over just a matter of a few years. However, this increase in popularity was accompanied by a parallel increase of emergency department presentations due to this means of transportation. Now, past literature stipulated that most such types of injury are mild. However, there was a consistent association with craniofacial and upper limb trauma. Hence, we wanted to also explore in our particular population whether there are specific orthopedic patterns of injury caused by the use of e-scooters. The study objectives are therefore threefold. First of all, to analyze epidemiology and temporal patterns of e-scooter-related trauma, to explore how much this type of injuries burden the orthopedic department of our hospital, as well to perform dedicated subgroup analyses of the upper limb injury articulations. To answer these questions, we performed a retrospective observational study at the emergency department of our hospital, spanning from July 2023 to December 2024. We went through the electronic medical records of all emergency room admissions and selected our patients by using specific keywords like e-scooter, monopattino elettrico, as well as their discharge papers. Our total cohort consisted of 392 patients, out of which we thereafter performed two selective subgroup analyses. The first one focusing on shoulder fracture cases, and the second one on elbow fracture cases. To answer the first question of today, as you can appreciate on the left side of the slide, we explored the demographics of our patients, and indeed the predominant profile of our patients were young males. Almost 70% of our cohort were males, and almost 45% of our patients belong to the 18 to 29-year-old age group. As far as the temporal distribution of such accidents is concerned, as you can see on the right side of the panel, we saw a rapid increase of e-scooter incidents during the weekends and during the warmer summer months. This reinforced our hypothesis that e-scooters are not only used as means of transportation, but are closely associated with recreational use and social activity as well. In accordance to past literature and international literature, we also found out that the majority of our cases were indeed soft tissue injuries and contusions. However, 1 in 3 patients did indeed sustain a fracture. When it comes to the body distribution of such injuries, they were mostly found in the craniofacial area, followed by the upper limb, and lastly the lower limb. Therefore, we wanted to further specialize and take a closer look at the fractures that were sustained on the upper limb. Hence, we performed the two subgroup analyses. The first one, regarding the shoulder articulation, consisted of 23 patients, and the most common diagnosis was a fracture of the clavicle, closely followed by a fracture of the proximal humerus. Most cases were due to a loss of balance and accidental fall from the vehicle, while from a biomechanical perspective, most injuries were attributed to the so-called fall onto an outstretched hand mechanism that is better illustrated on the slide below. Most of the patients in our group were treated conservatively in an outpatient setting. When it comes to the second subgroup analysis we performed, which was again explained by the fall onto an outstretched hand mechanism, we had a much more clear predominance of radial head fractures that represented 2/3 of the total cases, while combined with the fractures of the olecranon, they made up 90% of our cohort. Another interesting orthopedic pattern we saw was that the concomitant presence of radial head, together with proximal ulna fractures and elbow instability, form the so-called terrible triad that appears to be increasingly relevant in patients of e-scooter accidents. Regarding a few words about the fall onto an outstretched hand mechanism, it is when you lose balance, you fall on an extended hand because you try to protect yourself. And so there is a vertical transmission of forces from the impact alongside the whole upper limb, proximally towards the shoulder girdle, leading to the shoulder and the elbow articulations being particularly prone to fractures and other types of injuries. Lastly, when it comes to the elbow subgroup, there was a much higher rate of hospital admission with requirement for orthopedic surgical correction of the fracture. The above-mentioned data have several clinical and public health implications. Hospitals should anticipate an increased orthopedic burden and workload, particularly during weekends and warmer summer months, and should therefore provide the development of dedicated evaluation algorithms and rapid protocols, particularly focusing on the upper limb and craniofacial areas for possible fractures. The triage doctors should also be aware that young male patients are at an even increased risk of having sustained an e-scooter injury. While to prevent such cases, public health domains should underline the importance of using helmet and other safety equipment, as well as provide a proper rider education and provide also an adherence, a more effective adherence to the latest Italian traffic law. Moreover, because most of the cases were due to accidental falls from the vehicle, which are even more pronounced in historical center areas that are lined by cobblestone and other uneven pavements, we strongly suggest a better urban provision of dedicated micro lanes for such types of vehicles. And even though the latest Italian law does not strictly require for it, we would strongly recommend for the possession of a driver's license, so at least the drivers have a basic idea of the traffic law. To conclude, it becomes evident that e-scooter trauma is a new but very relevant source of urban trauma worldwide. And hence it poses an important orthopedic burden, particularly due to upper limb injuries and even more so upper limb fractures. Therefore, prevention strategies and proper adherence to the law remain essential. Thank you very much for your attention.
Thank you. This is an interesting work and very well presented with some social implication, I would say. We have a question from...
Thank you very much. Very, very interesting. I have a question. Do you have any data on understanding if the state of the streets make a difference. In other words, did you investigate where the spontaneous falls happen?
This is important.
Okay, so the problem is that because this was a retrospective study, in our electronic medical records, many times the exact mechanism of injury was omitted. But other international literature and a few cases where this was implicitly stated, we saw that many people fell on potholes or abandoned garbage cans or even stationary objects. And I think that all of you have wandered around the historical center. The cobblestone pavement is even more dangerous for such injuries because there's a constant bouncing movement. So some of the rental companies have indeed banned using the e-scooters in selected areas, but this is not enough.
May I ask, did you have the chance, or in the future, will you compare with standard scooter? Because I mean, my feeling is a lot of people is taking this e-scooter without any previous skill. Usually when you fall from your motorcycle, you grab.
You're a biker, right? Not a motorcycle. He's a biker.
I'm a biker, but I'm using a motorcycle since I was 14, maybe 14 years of age. So my feeling is a lot of people jump on this stuff without any experience, and how you are able to fall or to control your fall could make a huge difference.
Exactly. That's one of the biggest problems because it looks like a toy. And with the latest law, it is only required that someone is 14 years old to ride it. There's no requirement for a driver's license. And even if someone is mature enough, still at 14 years of age, you have no experience of the traffic law or how things work. That's why we push really for legislative changes. Also because during a biker like you or like anyone else, they need at least the possession of a specific license to be able to drive it. And there's better provision for protective equipment, while for the e-scooter people think in general that there are lower velocities and hence there is no need for a helmet or elbow pads. This is not the case because you're even less protected in the case of an e-scooter. So yeah, that's why it's a very relevant point.
Yeah. Totally agree. Thank you very much. Okay, it's now time for Margarita Flores. She did work in the surgery department of Sant'Andrea, and Professor Carrano, one of the newest top players of our degree course, will introduce her work.
Good morning, everyone. It's my great pleasure and honor to present Margarita Flores today. She's one of the most brilliant students we had in the department from our honor course. Today, we live in a world where everything is tailored. And so is surgery. We are moving towards tailored surgery, and this is as most important in the field of metabolic and bariatric surgery. Today, also a very important topic is the application of artificial intelligence in several aspects of medicine and surgery. And Margarita today will show us how these two important elements can work toward a better care for our patients. Please, Margarita, the floor is yours.
Thank you, Professor, for your kind introduction. I would like to thank the members of the committee and the President Damati. The title of my thesis is Towards Tailored Metabolic Surgery, a multi-center prospective study for AI-based measurement of total small bowel length. Obesity is a chronic multifactorial disease characterized by excessive or abnormally distributed adipose tissue with a body mass index greater than 30 kilograms per square meters. In 2022, 23% of adults living in Europe were affected by obesity. And for this reason, in 2025, the Lancet Commission proposed a new clinical classification framework into preclinical and clinical obesity. Preclinical obesity is defined by just a BMI greater than 30, while a clinical obesity is defined as a BMI greater than 30 in the presence of organ dysfunction and or reduced ability to conduct daily activities. There are several strategies for the management of obesity, including lifestyle modifications, targeted pharmacotherapy, and surgical interventions. Among these, metabolic surgery remains the most efficient in terms of long-term weight loss and resolution of comorbidities. And since several of the bariatric procedures act by reducing the length of the small bowel exposed to nutrients, the total small bowel length plays a definitive role in determining the surgical outcomes. In our systematic review that was published in May 2026 in Obesity Surgery Journal, we remark how the total small bowel length is highly variable in humans, ranging from a minimum of 2 meters to a maximum of 12 meters. Despite this, most of surgeons choose not to measure routinely the total small bowel length intraoperatively, this to avoid the prolongation of operative time and to decrease the risk of iatrogenic bowel injury. To address this clinical gap, our primary endpoint was to set up and validate a reliable and reproducible automated method for preoperative measurement of the total small bowel length in patients undergoing metabolic surgery. Secondarily, we wanted to assess the real-world feasibility of CT and MRI imaging modalities in the assessment of total small bowel length, comparing it with the intraoperative laparoscopic measurement. Ultimately, we wanted to build an AI tool to automatically measure the total small bowel length and the cross-section imaging. Our study is a multi-center prospective study involving 3 centers in Italy, Sapienza at Sant'Andrea Hospital, University Federico II of Naples, and the University of Padua. After the enrollment, the patients underwent MRI and CT scan with oral contrast, after which the images were manually segmented. Then the patients underwent the laparoscopic bariatric surgery, during which the total small bowel length was measured twice. All these data were then used for training and validation of the artificial intelligence tool. After the cross-sectional imaging acquisition, the images were segmented using a semi-automatic software called the 3D Slicer. We isolated in this way the bowel geometry in order to obtain the total intestinal volume and the average bowel diameter. The median segmentation time was roughly 3 hours, and this data were then used to estimate the total small bowel length using 2 formulas. The first one is a well-validated formula in literature by Marie and colleagues that includes only volumetric data, while the second one is a new formula by Professor Mascolini of our engineering team of the University of Padua that includes also the individual bowel diameter, so eliminating the cohort-dependent linear bias. After, the patients underwent laparoscopic bariatric surgery, during which the total small bowel length was measured twice, starting at the ligament of Treitz up to the ileocecal valve, moderately stretching the bowel tissue using a laparoscopic forceps graduated at 5 centimeters. Coming to the clinical results, we included 101 patients, of which 67 were females. 94 patients underwent metabolic surgery, and 7 patients were excluded from the study. Sleeve gastrectomy was the most performed procedure, followed by one anastomosis gastric bypass and Roux-en-Y gastric bypass. Preoperatively, the mean BMI was 41.4, and 60% of the patients belonged to class 3 obesity. Coming to the surgical measurements, our data confirmed the incredible anatomical variation of the total small bowel length with a mean of roughly 7 meters, ranging from 5 to 11 meters. Moreover, we found a statistically significant positive correlation between the standing height and the total small bowel length. The duration of the total small bowel length measurement consumed 15% of the total operative time, and more importantly, importantly, in 5% of cases, there were complications associated to total small bowel length measurement, including two intestinal perforations. We then checked the concordance between intraoperative and radiological measurements. In particular, using the new formula by Mascolini, we found a concordance of 77.5%, while using the formula by Maria and colleagues, the concordance was slightly higher of 79%. All these data were then used to train and validate in a subset of patients the AI tool, whose performance was measured with the DICE index and intersectional union. In this case, magnetic resonance enterography outperformed the CT enterography, yielding a DICE index of 71% and an intersection union index of 78%. So it has a great potential to become the gold standard tracking modality in this case. In conclusion, we said that the total small bowel length is highly variable in humans, supporting the choice of a tailored over fixed limb lengths. At the same time, intraoperative measurement carries a complication risk of 5% and also prolongs the operative time, so a preoperative measurement of total small bowel length can be implemented since it shows a good concordance with the intraoperative one. Moreover, the implementation of an AI tool to automatically measure the total small bowel length and the preoperative imaging can enable a patient-specific preoperative planning. So in conclusion, upon replication of the study on a larger cohort of patients, a tailored metabolic surgery represents a step toward a truly personalized treatment of obesity. Thank you.
Thank you. This is extremely interesting and very well presented. Are there any questions from the floor? While he's coming, I want just to ask you more. I was thinking this high variability of the bowel length, which I'm aware of because at autopsy it can be heaven, it can be hell. Does it influence, or you told me some complications, but also the metabolic state of the patient, is it related or not to this variable?
Yes,
I was thinking also to cachexia, you know.
Actually, sorry, related to this, I was thinking to the lean mass, because when you deal with body mass index, but I was thinking whether, I don't know, sarcopenic obesity is something different.
Yes, thank you for your questions. In our cohort of patients, we didn't differentiate between the sarcopenic obesity, but what I can say is that, as I mentioned, we conducted a systematic review to investigate the role of total small bowel length in bariatric surgery, because since it is highly variable, as I said, the choice of a fixed limb length in some patients can lead to excessive malabsorption, while in other patients can lead to insufficient metabolic outcomes, so weight loss and resolution of comorbidities. So it is fundamental for surgeons to tailor the limb lengths according to the patient's total small bowel length.
You have anything to add?
Yes, just regarding sarcopenic obesity, yes, that's a very important aspect to take care of, and we are running other studies in parallel with CT scan and MRI to understand this preoperatively, and linking that to further project like this one with total small bowel length measurement, because as Margarita just said, that can change the metabolic effect of the procedure, and that was originally what I wanted to ask, but you anticipated me. Why should we go after a tailored metabolic surgery, and why should we go after measuring everything, so especially from the malabsorption point of view? So this is what I wanted you to clarify to the podium, but you already did.
Thank you.
Thank you. Okay. We now have two candidates who did their thesis work under the supervision of Professor Nenna in pediatrics. The first one is Francesca Lupi. Please, Raffaella.
Good morning, everyone, and it's a real pleasure to introduce the next candidate. Francesca was awarded funding by a Technopol award called for proposal, and we found a company that joined the project, and this company was producing this new probiotic, and she will talk about the very preliminary data of this double-blind placebo-controlled study on the most frequent bacterial upper respiratory tract infection, that is the Streptococcus group A infections.
Hello everyone, thank you Professor for the introduction and thank you for the presence and all the committee. So as the professor already said, my thesis is about the efficacy of this probiotic Streptococcus salivarius evolution K12 in reducing the incidence of pharyngotonsillitis caused by Streptococcus pyogenes. So acute pharyngotonsillitis is one of the most common pediatric diseases, infectious pediatric diseases. In particular, it is estimated that approximately 32% of children experience at least one episode of sore throat each year. In particular, Streptococcus pyogenes is the most common bacterial cause of acute pharyngotonsillitis, and for this reason, a large amount of antibiotics are prescribed. The antibiotic therapy is, of course, fundamental for bacterial infections, and in this specific case, it decreases the symptom duration and the risk of future complications. However, the recurrent infections, repeated antibiotic exposure can lead to of course, microbiota alteration and also the resistance to antibiotics. For these reasons, we started from these limitations for my thesis to improve possible clinical diagnosis for acute pharyngotonsillitis and also to evaluate if there are alternative preventive strategies for this disease. So for the first point, we evaluated the role of cough as a negative clinical predictive factor in the Merck-Isaac score. So for the diagnosis of acute pharyngotonsillitis, the microbiological diagnosis is fundamental. However, in day-to-day clinical practice, the clinical evaluation is fundamental, and for this reason, the Merck-Isaac score is the primary score that it is used. However, this score has a limited specificity with a large amount of false positives. For this reason, based on the fact that on the observation that cough is a very common symptom in children during the winter months, and on the clinical hypothesis that these symptoms, cough especially, is more commonly associated with viral pharyngotonsillitis, we assigned the negative point to the presence of cough compared to the original score in which the absence of cough has a positive point together with all the other points. Regarding the preventive strategies, the alternative strategies to the treatment of pharyngotonsillitis, Streptococcus salivarius, which is the probiotic, is the most common non-pathogenic commensal bacterium of the oral mucosa. K12 it is a specific strain of Streptococcus salivarius that has been first isolated by Robert Tag in 1989 from the saliva of a healthy child, and later on numerous studies have proved the efficacy of this probiotic in reducing recurrent group A Streptococcus pharyngotonsillitis, especially through the effect of bacteriocins, which are compounds that act specifically against this bacterium, in particular salivarisin A2 and B. However, recently it has been discovered that these pathogens, so group A Streptococcus, is able to evade the antimicrobial effect of this probiotic, in particular by producing a cysteine protease called SPB. And for this reason, a genetically engineered derivative has been developed, also implementing the increased production of a salivobactin, which is another important antimicrobial compound. So the objectives of the study are to compare the sensitivity and specificity of the original Make-Isaac score with a modified version that assigns a negative point to the role of cough, to the presence of cough, and to evaluate the efficacy of bactobacillus in reducing the incidence of recurrent gut pharyngotonsillitis. This was a randomized, double-blind, placebo-controlled trial. My thesis in particular is a pilot, so all results must be considered preliminary. And I hope to be involved also in the future in this thesis, in this study, and see more conclusive results. In particular, the population involved was children aged from 3 to 16 years, accessing the emergency department of Policlinico Umberto I between February and May 2026. This is a very in-depth clinical flowchart. I will try to make it simple. Children accessing emergency department that had compatible symptoms with gut pharyngotonsillitis underwent a rapid antigen test. If the test was positive, they underwent 10-day course of amoxicillin therapy. If negative, they didn't receive antibiotic therapy. And the control group was selected from patients accessing the emergency department for reasons different from the infection diseases. All of them, and these were the carrier control group, all of them underwent a randomization in 2 groups, one receiving bactobacillus and one placebo, and they were followed up for 3 months, at the end of which an antigen test was performed, and again this was followed by 3 months of follow-up. Regarding the results, a total of 15 participants were selected, 14 of which were symptomatic and 1 was the control. 9 out of 15 had a previous gut infection. For bactobacillus results, we assessed the feasibility of this study that proved to be very good, with a 90% adherence, a good tolerability to the product, only 1 recurrence during follow-up, and 1 patient with poor compliance. We hope in the future to have a larger group of patients to also evaluate the efficacy of this probiotic. Of course, this is an ongoing study, so recruitment is still ongoing. Regarding the Make-Isaac score results, we set a cutoff value of equal or more than 4. And the reference standard was the rapid antigen detection test that was positive in 10 out of 14 symptomatic subjects. And then, of course, we compare the sensitivity and specificity of the 2 scores. In the original score, we can see 100% sensitivity. However, the specificity, as we said before, was quite low, with a 50%, so there were 2 false positive patients. In the modified score, we can appreciate an increase in specificity to 75%, however, with a detriment of sensitivity to 40%. So 6 gas-positive children positive to the rapid antigen test were missed in the modified score, and this is a clinically concerning result, because of course these patients, if they didn't undergo also the rapid antigen test, they wouldn't be able to receive antibiotic treatment, which could lead to complications in the future. And the absence of cause was recorded in 9 patients. So to conclude, we proved the feasibility of the Evolution K12 probiotic that was well tolerated in our cohort. For what concerns the Mikasa score, we recorded in this preliminary pilot study an increased specificity, but a substantially reduced sensitivity. So we can say that there is some sort of role of cough that must be studied more deeply in the future. Finally, microbiota-based approaches may represent a future adjunct strategy for preventing recurrent gas-pharyngeal tonsillitis, hopefully also reducing antibiotic exposure. Our goal is also to expand the study to primary care settings, so recruitment also in the primary pediatrician, and so to enlarge the number of participants to the study. Thank you very much for your attention.
Thank you for this interesting study. Very well presented. Marcella, you were following with interest. Have you got some questions?
Just a question about the age. Was there a difference in the age of patients?
So the mean age was 6.3. Most of the children were less than 10 years old, yeah.
But the adherence to the therapy was somehow related to the age, or?
I would say no. Of course, the results are not complete, but the case of poor compliance was a small child, of course, that just for the powder solution of the product wasn't able to continue the therapy. But for all the others, even if they were small children, of course, during the recruitment, the doctors and me, we explained deeply how to assume the product that was to be assumed before going to bed, so without chewing and without eating or brushing teeth, so that the probiotic could also insert into the oral mucosa.
For how long do we have to, do they have to take this probiotic?
For 3 months.
For 3 months, okay.
Yes.
The next candidate is Flaminia Mudu. Again, Rafaela, please, can you introduce her work?
Okay, thank you. It's a real pleasure for me to introduce Flaminia. She has been working at our department over the last 2 years, and she was really deeply involved both in clinical and in research activities, and we really appreciate her activities and hard-working habit and her kindness. Today she will talk about acute viral bronchiolitis, and she will focus on the respiratory sequelae after 2 years of follow-up.
Good morning, everyone. Thank you to Professor Sanenna, but also thank you to the President of the Commission, Professor Sadamati, and all the professors of the Commission, and thank you all for being here. So the first thing that I would like to do is giving you a clinical background of what is bronchiolitis, which is an acute viral infection of the infants, in particular the most common lower respiratory tract infection, and the leading cause of hospitalization in the first year of life. Moreover, nowadays there is still no target therapy, but only supportive therapy. And the main etiological factor is respiratory syncytial virus, which is also associated to a more severe presentation of the disease. Moreover, even though this is a viral disease, we found out that there is that the neutrophilic inflammation with the response that should be protective normally, in this case, can be pathogenic. So all these factors together can lead to a higher risk of recurrent wheezing and then the development of asthma. What we wanted to do is to understand if there are any kind of predictive factors that could tell us which patients are at high risk. So the primary objective was to understand if the neutrophilic inflammation at admission and then the respiratory function could predict in general the risk of wheezing. And then we wanted to understand if the phenotype of the nasal neutrophils could affect in any way the course of the disease. And of course, if we could find any kind of early biomarker that could tell us more. So this was a prospective cohort study involving 154 patients, and then on a smaller subgroup of 33 patients on which it was possible, we performed the nasal cytofluorimetry. The inclusion criteria were infants being younger than 1 year old that were born at term and previously healthy, but also that received a diagnosis of bronchiolitis and were hospitalized for this during 2023-2024 season. And then, of course, since they are minor, the parental consent. So what we did at first is measuring the peripheral blood count, and in particular this was done to see the levels of neutrophils, and we are talking about age-adjusted neutrophils because the levels of neutrophils in the first year of life can change a lot physiologically, and so a value that could be normal at 1 week could be abnormal at 1 month. Then we performed the nasal cytofluorimetry, which was done in order to see which were the most abundant cells, and also if they expressed any kind of biomarker that could help us understand the severity of the disease and the pathogenesis of the disease. And moreover, we performed tidal breathing analysis. In particular, we considered the TPTFT value, which is the time to peak tidal expiratory flow over the total expiratory flow. And this is a key value in infants because they cannot collaborate in order to do an active spirometry. And so this is done on a patient that doesn't collaborate on a spontaneous sleep that has been already fed and that isn't in any position that could alter the lung function. And it tells us about lung obstruction. So the lower the value, the higher the obstruction. So in bronchiolitis, it is a key value. Finally, we collected data about wheezing at follow-up, in particular at 1 year after infection and then at 2 years after infection. We called the parents and asked if they had to use the bronchodilators 2 or more times. The reason why we put 2 as a key number is because we wanted to avoid confounding factors like post-infectious wheezing. So the first result that we obtained is that patients could be classified in those that had high levels of neutrophils and low levels of neutrophils. And as you can see, the patient with high, so with orange, had a lower lung function, especially in the first 3 months. But then this could resolve, and this is probably because we have also other factors like genetic factors that are the major players. And then afterwards, we also saw a trend of correlation with wheezing, both at 1 year and then at 2 years. For what concerned the lung function, we saw that a lower value at admission of TPTFT, so a higher obstruction, was also correlated with a lower value at 1 month. And we can see that also always at admission, a lower value was directly correlated with a higher risk of wheezing, both at 1 and 2 years of follow-up. Thirdly, we performed the nasal cytofluorimetry. What we obtained is that neutrophils were the most abundant cell population, and this could clearly be subdivided into 2 groups, those that had high expression of CD45 and those that had low expression of CD45. We saw that this expression was directly correlated with maturation and activation. Indeed, those that had a lower expression and so a lower maturation and activation had a higher trend of wheezing. Finally, we also saw that there were other factors that were directly correlated to the severity of the disease at admission, like, for example, a worse severity score or the need to perform a chest X-ray, which is not routinely done in bronchiolitis, that were all correlated to a higher wheezing. And finally, also the fact that RSV positivity, which was present in 77% of cases, so most of them, was also associated to a higher severity and so indirectly to a higher risk of wheezing.
So to conclude, we understood that neutrophilic inflammation has a key role in the development of the disease, and so in both the development of a lower pulmonary function at admission, but also a higher wheezing at follow-up. Moreover, for what concerned the CD45, unfortunately, we were not able to reach the statistical significance, and this was because the cohort was very small. But we saw a trend of association, and so we think that it should be further studied. So what we understood is that we need a multidimensional stratification of the risk, and we cannot focus only on one single value. For what concerns the limitations, of course, unfortunately, we had the reduction of sample size at follow-up, especially at 2 years. And as I said, the cytofluorimetry subgroup was too small to reach the significance. And finally, the fact that wheezing diagnosis, even though it is approved by pediatric literature, it is prone to recall bias from the parent. So, of course, this could affect the data. Thank you, everyone.
Thank you. Very nice work. Very nice presentation. Are there questions? There are 2 questions from the Marcella first, of course, and then Paolo. No, prima Paolo. Marcella. You know 5.
Thank you very much. Just a very short question. The ratio, the neutrophils, lymphocytes, which helps in adults, sometimes in acute infections, does it help in small children where lymphocytes are usually higher?
Thank you for your question. So we prefer to focus on neutrophils because there was already literature stating that they could be pathogenic during the disease, and so we did measure the lymphocytes, but it wasn't really relevant for the study.
Could you please make a comment on your last slide? The last 2 columns, I don't know if you skip because about the treatment, in particular steroid treatment, how he can influence your data.
Of course. So actually we saw that normally we don't use corticosteroids. So the fact that the corticosteroids are needed to treat the patient means that there is a more severe disease. And also this is also valid for antibiotics. And so for this reason, the need to use this treatment are also correlated with a more severe disease and so correlated with wheezing. Did I answer your question? Yes.
Thank you.
Thank you.
We have 2 candidates now with Professor Gianluca Mennini, one of the most appreciated teachers of our degree course. And I want to stress the fact that there are many, there is an increasing number of theses in surgery, despite the lack of interest. It's apparent, but I'm sure something is rising back. You will have nice surgeons. One will be Ortensia, which is introduced by.
We hope so.
We hope so.
Good morning to everybody. Thank you, President. Thank you to everybody. It's a pleasure to introduce Ortensia. She worked with us and made a great job. Her thesis regards the incisional hernia after orthotopic liver transplantation. It is a retrospective case control study. It is an important disease that affects our transplanted liver population, and she made a great job of looking to all patients of our community of the last 6 years. So please, Ortensia, show us your work, please.
Thank you, Professor. Thank you to the President and to all the professors of the committee. So first of all, I want to do a little overview on liver transplantation. We know that it is the gold standard treatment for the patient with both chronic but also acute liver diseases, and the indications are a lot. But what is important to say is that in the last decades, the surgical technique itself has improved a lot.
So nowadays we are not worried anymore about the immediate perioperative survival of the patient, but mostly about some long-term complications. One of the most important is incisional hernia. That is a protrusion of the intra-abdominal contents through a defect in the abdominal wall, of course in a previous surgical site. The clinical presentation ranges a lot because we can have asymptomatic patient or patient with an impaired quality of life, like in the video, that so has have an impaired also physical presentation, physical activity, and also image, and also the possibility of developing some complications, as for example, bowel obstructions, incarceration, strangulations, fistulas, that can require further surgeries to, of course, treat the complication. The incidence is higher with respect to the general surgery. We have the presentation that is quite high, like from 5 to 43%, and the etiology is multifactorial. In fact, we can have impaired wound healing, chronic immunosuppression, obesity, diabetes mellitus, ascites, surgical factors that can also contribute together to the development of this complication. Our aim was to identify the different risk factors predictive that so can be associated with the development of the hernia post-transplant, and also to evaluate the incidence and look specifically to all the variables of the patient that so can be patient-related as age and gender, BMI, and we analyze the pre-transplant, post-transplant, and also with the development of incisional hernia, diabetes mellitus pre- and post-transplant, ascites post-transplant, or transplant-related factors like MEL score, liver disease etiology, if the patient had some previous or post-abdominal surgery and possible complications, and immunosuppression, in which we found mostly 3 immunosuppressor drugs. There are everolimus, mycophenolate mofetil, and tacrolimus, on which we will focus mostly on the mTOR inhibitors, so everolimus. So our study was a retrospective case control study that included patients ranging from January 2020 to December 2025. We initially included 125 patients who underwent orthotopic liver transplantation, of which we then selected 90 patients that are our cohort because of exclusion criteria like loss of follow-up due to death, retransplanted patient, or incomplete clinical data. And of this total cohort of 90 patients, we divided 2 groups. The case group composed by 22 patients with a clinically or radiologically confirmed hernia, and the control group with the remaining patient that does not develop the hernia, so 68 patients. And from our analysis, we set a threshold of significance, there is P less than 0.05. So these are all the variables that we analyzed. As we can see, the values are mostly comparable between the 2 groups, except for some specific ones like BMI, ACV etiology, so hepatitis C virus, and immunosuppressant drugs. And looking specifically at them, the first one that we analyzed is that so has a significance in our study was the etiology related to hepatitis C virus. That, as we can observe from the graph, has mostly a prevalence in the cases group with respect to the control group, with a significance that is important because the P is 0.008. Another result that we obtained that is actually not statistically significant but important because it is in line with previous study is the post-transplant BMI, in which we can observe from this graph that initially pre-transplant patient has mostly a comparable situation, but immediately after the transplant, in the control group that so does not develop the hernia, the BMI decreases significantly with respect to the cases that remained quite high, and as we can observe, it continues to raise at the hernia onset, and it becomes even higher with respect to the pre-transplant condition. So this, of course, is in line with previous study, even if in our study is not significant. And then the last parameter that was important is the immunosuppressive drugs, in particular with the focus on the everolimus drug, that as we can observe is mostly utilized in cases group, and we have a high percent of patients, almost 32% with respect to the control group that is only 7.4, and the P in fact is also significant, we have 0.008.
So our results are that everolimus use and ACV etiology are actually independent predictive risk factors in the development of incisional hernia. And of course, known that there are some predictive risk factors, we can start some protocols to, of course, prevent the development of this complication, stratifying the patient depending on the possible risk, and so starting some preventive strategies in high-risk patients, as for example, nutritional intervention, but also mechanical support with some abdominal binders, and also surgical prophylaxis with utilization of some prophylactic mesh that so will also avoid a further surgical procedure to the patient with the development of the hernia. In this image, we can observe a patient after hernioplasty, so with the second surgical procedure to restore the hernia in the abdominal wall, and in fact we can observe a great abdominal wall integrity, and of course the quality of life of the patient is improved. Thank you.
Very nice work and nice presentation. Do you have any questions about how do you explain the association between everolimus and, the possible explanation of
So everolimus is a drug that is mostly given to patients with an oncological history because it inhibits the proliferation of fibroblasts. But of course, this impaired proliferation of fibroblasts can also impair the wound healing. So it is useful because of the etiology of the patient, but can be associated with the development of this problem then.
Thank you.
Thank you.
The second candidate is Nikki Deitri.
So again, good morning. I present Nikki. It's a pleasure. She made this work thesis on the use of kidneys with multiple renal arteries in living kidney donation. It is a systemic review, meta-analysis, and meta-regression. It's an important work, especially nowadays that we are in our center celebrating the 60 years after the first kidney transplantation made here in Sapienza and Policlinico Umberto I. From that time, our center performed quite 800 of living donation procedures, so it's an important work, and Nikki, please try to explain us. Thank you.
Thank you. Welcome, everyone. I would like to thank our president, Professoressa Damati, all the committee, especially my relatore, Professor Gianluca Mennini, and my correlatore, Professor Quirino Lai, for their precious help. So, the topic of my thesis is the use of kidneys with multiple renal arteries in living kidney donation. This is a systematic review, a meta-analysis, and a meta-regression. So kidney transplantation is the surgical procedure during which a healthy kidney from a donor is transferred to a recipient. The donor can be a healthy living donor or a diseased donor. Our study focuses on living donation. The recipient, on the other hand, is a patient with end-stage renal disease, having an estimated glomerular filtration rate of less than 15 milliliters per minute per 1.73 meters squared. And indeed, kidney transplantation is the treatment of choice for eligible patients with end-stage renal disease. And it's preferred over dialysis because of its superior outcomes relative to the quality of life of the patients and the overall survival of the patients. However, in the recent years, there is a clear increase in the incidence of end-stage renal disease, and this has led to long waiting lists for patients and a clear mismatch between patients awaiting transplantation and the availability of kidneys that are donated, which is limited. A strategy to increase the pool of the donated kidneys is the expansion of the selection criteria for living donors. A tremendous example of this expanding criteria is the use of kidneys
with multiple renal arteries in living kidney donation. Multiple renal arteries is an anatomical variation in the vasculature of the kidney in which the kidney is supplied by multiple renal arteries instead of one single renal artery. And this is associated with increased technical surgical complexity. Transplantation with kidneys with multiple renal arteries and the expansion of selected kidneys to be donated was feasible because of the introduction of less invasive techniques for the donor nephrectomy, meaning the use of laparoscopic techniques instead of open surgery. Relative to the argument, recent evidence demonstrates that long-term recipient outcomes are comparable between kidneys donated for living donation between multiple renal arteries and single renal arteries. However, important questions remain unanswered relative to the donor outcomes and early recipient outcomes. Therefore, the objective of our study was to compare the perioperative donor outcomes and the early recipient outcomes between living kidney donations involving multiple renal arteries and single renal arteries. For this reason, we conducted a systematic review, meta-analysis, and a meta-regression following the PRISMA diagram, having as databases PubMed and Central. For the eligibility criteria, studies were considered eligible if they were comparing living kidney donations involving multiple renal arteries and single renal arteries, if they were reporting at least one perioperative donor outcome or at least one early recipient outcome giving extractable quantitative data. Multiple renal arteries were defined as the presence of 2, 3 or more renal arteries or the presence of accessory renal arteries, as long as the two groups were reported separately. For the donor nephrectomy, the surgical techniques that were accepted were the laparoscopic, hand-assisted laparoscopic, pure retroperitoneoscopic, and robotic-assisted techniques. The outcomes we studied in the meta-analysis were the following. For the perioperative donor outcomes, we studied the donor length of stay, the donor operation time, the estimated blood loss, and the conversion to open surgery for the donor nephrectomy from a laparoscopic or robotic technique. For the ischemia times, we studied the primary warm ischemia time and the cold ischemia time, while for the early recipient outcomes, we studied the delayed graft function, acute rejection, urological, and vascular complications. The covariates we studied in the meta-regression were the population year, the surgical technique for the donor nephrectomy, the large cohort size, the presence of 3 or more renal arteries, and the use of the right kidney instead of the left. For the statistical analysis, continuous outcomes were reported as mean differences, while binary outcomes were reported as odds ratios. During the first identification phase, we identified 154 records, and after the screening phase with the application of the eligibility criteria and after reports were excluded for being non-English or reviews or letters or case studies, we concluded having 17 studies that were included in the statistical analysis. So the results of the meta-analysis that reported a statistically significant increase in the multiple renal arteries group over the single renal arteries group were the conversion to open surgery, the cold ischemia time, the donor operation time, and the primary warm ischemia time, having a p-value of less than 0.05. Importantly, the rest of the outcomes, meaning acute rejection, delayed graft function, urological complications, vascular complications, donor length of stay, and the estimated blood loss during the donor nephrectomy were not affected by the presence of multiple renal arteries, so the two groups were similar in this aspect. The most relevant results of the meta-regression, which was a univariate meta-regression, were the association between cold ischemia time and publication year, with more recently published articles reporting increased cold ischemia time in the multiple renal arteries group, and the association between donor operation time and pure laparoscopic technique. The findings of our study are consistent with measurable increase in the technical complexity of multiple renal arteries, reflected by the longer donor operation time, the increased conversion to open surgery during nephrectomy, the longer primary warm ischemia time and longer cold ischemia time. But importantly, this technical complexity did not translate into donor morbidity. Indeed, there was no difference between the two groups between estimated blood loss and donor length of stay, and this technical complexity did not translate into early recipient complications. Indeed, there was no difference between the two groups between delayed graft function, acute rejection, regarding urological complications and vascular complications. In conclusion, we can say that multiple renal arteries for living kidney donation is feasible and safe for both the donor and the recipient. And despite their technical challenge, this technical challenge should be considered a manageable technical challenge. And given that the appropriate surgical expertise is properly provided and available, we suggest that kidneys with multiple renal arteries can continue to be used in living kidney donation. And therefore, hopefully, more and more patients with end-stage renal disease can receive a timely transplant. Thank you for your attention.
Thank you, Nikki. That was very, very nice and really well presented. Are there any questions for you? So, no, just a curiosity. I don't know exactly how difficult it is or feasible it is because I'm not a surgeon, but which is the impact of the surgeon of the skill? Because in here, okay, this is a meta-analysis, but would you suggest to perform this kind of, to select this kind of organs only for centers with a very high experience or not?
Yes, definitely. This kind of transplantations, living donations involving multiple renal arteries should be done only in highly specialized centers with high volume of kidney operations and transplantations, and our department here is really excellent in this aspect. There is a great impact of the surgical expertise on the outcomes. Indeed, our study, the limitation of our studies was that the studies included in the meta-analysis were retrospective. Most of the studies studied one center, except of one study that reported 2 centers, and this is associated to some bias relative to the outcomes, relative to the expertise of the centers performing these kind of operations.
Thank you very much.
Thank you.
Our next candidate is Aurora Tasano. She did her work under the supervision of Professor Valentini, who is coming from the operating room. Right for her. Here we are. It's a typical surgical presentation.
Good morning, everybody. Thank you, Mrs. President. Thank you to the members. It's my pleasure to introduce Ms. Aurora Tasano, who attended in our department for 2 years. And the issue is, in my opinion, very challenging because reconstruction of the jaws is very challenging, and we usually utilize free flaps, so microsurgical techniques to reconstruct the mandible and the upper jaw. And now we have the possibility to reconstruct the mandible and the upper jaw with more simple techniques, but very, very nice techniques that are ideal, especially for patients with a poor performance status. Please, Aurora.
Thank to Professor Valentino Valentini for the introduction, and thank also to the committee and to Professor Giulia D'Amati. My thesis project is titled Maxillofacial Rehabilitation with 3D printed patient-specific supraosteal implants, a prospective cohort study on patients with severe jaw atrophy and patients with oncological jaw resection. Severe jaw atrophy is a highly prevalent condition present in over 45% of the adult population, with a female predominance and with the mandible being more severely affected than the maxilla. Chronic edentulism is the most common etiology, but we may mention also periodontal pathologies and congenital defects. On the other side, oral cancer, according to the most recent epidemiological data, accounts for 41% of all head and neck cancer, and head and neck cancer accounts for 5% of all cancer types worldwide, with an increase in incidence in the last decades, especially among women and young patients, and with the squamous cell carcinoma being the most represented diagnosis, accounting for 90% of all malignant neoplasm of head and neck region. The most important limitation of this condition in maxillofacial rehabilitation is the lack of adequate bone thickness to ensure an appropriate osseointegration of traditional endosseous implants. That's the reason why, as a standard of care for this patient, reconstructive options are available. In this slide, I reported two clinical cases. The first one is a case of a chondroblastic osteosarcoma of the premaxilla that was treated with a Brown type 2 maxillectomy, reconstructed with a fibular free flap. The second case is a case of a squamous cellular carcinoma of the mandible, treated with a mandibulectomy and reconstructed with an iliac crest free flap. Of course, this type of interventions carry an intrinsic high morbidity rate at the donor site. They have a higher rate of complications, and so they have an overall high reconstructive burden. And that's the reason why recent interest towards supraosteal implants is rising in the implantology field. These are custom-made titanium framework that, differently from traditional endosseous implants, are not drilled directly into the bone, but they sit on top of the cortical jawbone, and being custom-made, they perfectly adapt to the patient's anatomy and to the contour of the remaining bone, thereby avoiding the extensive regenerative procedure and offering a viable alternative to cases that would otherwise be difficult to treat. So the first objective of this study is to investigate the precision, advantages of rehabilitation success of the new generation of supraosteal implants, and being a recent, newly rediscovered field, we want to try also to bridge an existing gap in the literature on the use of supraosteal implants in patients with these conditions. The prospective study was conducted from March 2023 to December 2025 in close collaboration between the Department of Maxillofacial Surgery and the Department of Implantology and Prosthetic Rehabilitation of Policlinic Umberto I. Patients were enrolled according to inclusion and exclusion criteria that you can see in the slide, and then went through a multi-step digital workflow consisting of 4 standardized scans, 1 full arch scan of the maxilla, 1 full arch scan of the mandible, and an intermaxillary bite registration with the EvoBite, and an extraoral scan of the EvoBite alone. And then this data package, together with the high-resolution CBCT scan, were sent to the BTK, that is a prominent Italian implant manufacturer, that produced the supraosteal implants that was then sent to the surgeons. As an illustration of this surgical workflow, I reported a clinical case of a 52-year-old male with a diagnosis of squamous cellular carcinoma of the left maxilla that was treated with a Brown type 2 maxillectomy. As you can see in the above image, this is the bone defect left by the maxillectomy, and reconstructed with the perical flap, temporalis muscle flap, and below image you can see the complete mucosalization of the flap. Well, in the images in the center you can appreciate the digital planning of the supraosteal implant.
In this next slide, you can see above two intraoperative images. The first one showing the surgical, the supraosteal implant deployed over the cortical bone, and in the second, taken in the immediate post-operative, you can observe the screws where then the crowns of the teeth will be put. While in the below images, you can see the patient at 2 years follow-up. The first one showing a complete healing of the mucosa surrounding the supraosteal implants, and the second image offering a frontal view of the patient showing optimal aesthetic results. About the demographic distribution, the cohort was formed by 21 patients, 11 women and 10 men, with a mean age of 59.6 years, and an age range spanning 5 decades, from 32 years to 74 years, thereby shifting away from the traditional view that this type of procedure is exclusive of the elderly population. About the diagnosis distribution, severe jaw atrophy was the most represented diagnosis, accounting for 64% of the cohort. 38 implants were deployed over 21 patients, with the 2 implant maxillary setup being the most common configuration, accounting for 28.6%, so corresponding to 6 out of 21 patients. Finally, clinical outcomes were evaluated as an indirect measure of complication rate. No early complications such as wound infections, wound dehiscence, or bleeding were reported, while a single case of late complication, in particular bone resorption occurring beneath the supraosteal implant, was observed. That will result in the removal of the 2 maxillary implants and thereby resulting in an implant survival rate of 94.74%. So despite supraosteal implants are not today the standard of care, the study shows promising results, and for supraosteal implants being a minimally invasive alternative to extensive regenerative procedure. And also, I think this study is an excellent example of the integration of technological advancement to clinical practice, offering a reflection of the direction of modern medicine and also toward a more patient-personalized approach. Thank you for your attention.
Very interesting work, and very well presented. Professor Coletti has a question for you.
Thank you.
It was impressive. I was just wondering about the 5% of complications, of cases of complications, whether to solve this problem of the bone resorption, you could, I don't know, foresee a kind of tissue engineering approach as considering, I mean, what can be done for these cases that are
actually
severe,
so
then it's a problem.
Supraosteal implants are, as I mentioned, a renewed, a newly rediscovered field, because in the past, we know the use of these devices dates still the late 40s. So the novelty of this new approach is the fact that we integrate the digital technology and the digital planning in the surgical planning. So this already contributes to increase the low rate of complications and of course to understand if complication rate in the long terms are more or less present, we would need longer studies, longer longitudinal studies, because unfortunately the follow-up was of a minimum of 1 year. So I think already the digitalization of all the surgical planning tries to reduce as much as possible the complications for these procedures.
Yes, for sure. No, I was just wondering whether what can you do to, I mean, for these cases as an intervention, if there is already an idea for
that specific
generation or anything, if there is a plan or
for that specific patient, the immediate plan will be the removal of the implant. And it was an oncological patient, so eventually we can evaluate if there are indications, the possibility of an extensive regenerative procedure to use a free flap for the reconstruction. But for the immediate, the immediate solution is the removal of the implant.
Thank you. Thank you. We're getting to the end. The next candidate is Alessandro Vigna. He did his work under the supervision of Professor Vicentini. He's going to present.
Good morning. So I'm very happy to introduce Alessandro Vigna, who attended our outpatient clinic and the Laboratory of Clinical Immunology, working on a collaborative project with the Rheumatology Clinic on systemic sclerosis patients. So we focused on the role of platelets during the stages of the disease, and Alessandro will show us the results. The preliminary results. Alessandro is not only shown to be very curious and with a genuine passion for translational research. He also has a very nice attitude because he is always very kind and thoughtful and respectful for all patients and colleagues, and I think these are very important qualities nowadays, especially nowadays. So please, Alessandro. Thank you.
Thank you. Thank you, Professor Vicentini, for the very kind introduction, and thank you for the guidance throughout the entire project. Also, a dear thank you to Dr. Annalisa Villa, who is not here today, but who was really crucial throughout the entire process. So my thesis today is about the differential platelet function in very early diagnosis of systemic sclerosis versus established disease. So systemic sclerosis is a rare connective tissue disease, and it is characterized by a triad of vasculopathy, autoimmunity, and fibrosis. The clinical presentation of systemic sclerosis is highly heterogeneous and is oftentimes severe, involving skin fibrosis, interstitial lung disease, pulmonary hypertension, GI, and renal involvement. And because the complications are often severe, some time ago there was the development of criteria for the very early diagnosis of systemic sclerosis, the so-called VEDOS, which were developed to detect patients at highest risk for disease progression in order to have a strict follow-up of these patients. So here on the right you can see the different complications of systemic sclerosis, mostly affecting the skin, but also the lungs, the GI, and musculoskeletal systems. So here you have the VEDOS criteria to make a diagnosis of VEDOS. We have two levels. Level 1, which include the red flags, Raynaud phenomenon, puffy fingers, and ANA, and level 2, which includes capillaroscopy and specific autoantibodies. And if both levels are present, then you have a diagnosis of VEDOS. Whereas on the right, you have the classification criteria for systemic sclerosis, which includes different categories, each one with a different score, and a score of 9 or more is required to classify a patient for systemic sclerosis. So as we said earlier, systemic sclerosis is based on this triad of fibrosis, autoimmunity, and vasculopathy. And platelets have an emerging role in this pathogenesis because they've been shown to link the three cornerstones of the pathogenesis itself. And this is by the production of specific mediators, including TGF-beta, serotonin, and HNGB1, but also by interaction with endothelial cells and leukocytes. And this action of platelets is mediated by a specialized repertoire of receptors, including the GP6 receptor and the P2Y12 receptor, which we will focus on later. So based on this background, our study aimed to investigate in vitro differences in platelet activation between VEDOS patients, patients with established systemic sclerosis, and healthy controls. So platelets were withdrawn from these three different groups of patients, and a platelet functional analysis was conducted by flow cytometry. So platelets were looked at by activation in unstimulated conditions and upon stimulation with ADP, convoxin, and TRAP6. So these were our results. We had 37 patients in total with a median age of 52. All patients in the study were females, which makes sense given the fact that it is a disease mostly prevalent in the female gender. These were our results of the platelet functional analysis. Usually when looking at platelet activation, we look at two markers, PAC1, which is a marker of integrin activation, and CD62P, which is a marker of alpha granule secretion. And in unstimulated conditions, as you can see, there was no difference between the three groups. The difference was seen when when the platelets were stimulated with convulsin, a sort of a collagen-like agonist binding the GP6 receptor. And in this case, platelets from patients with VEDOs were more activated compared to platelets from patients with established systemic sclerosis. And this was also seen when PAC1 and CD62P were looked at together. So once again, upon convulsing stimulations, platelets of patients from VEDOs showed increased activation compared to platelets from patients with established systemic sclerosis. Furthermore, what was observed was upon stimulation with ADP, there was an increased activation of platelets from systemic sclerosis patients compared to healthy controls. So overall, there is a difference in platelet activation between VEDOs patients and patients with established systemic sclerosis. So as we said earlier, platelets have different receptors which do different things. We're mainly focused on the GP6 receptor and the P2Y12 receptors. The GP6 receptor is important because it binds subendothelial collagen, and this activation, which we see in the study, is potentially linked to endothelial damage, and which may be associated with the VEDOs patients which have an earlier stage of the disease in which in which endothelial damage is more important, whereas the P2Y12 receptor, which binds ADP, is more involved in amplification of the platelet response, and this greater activation in patients with systemic sclerosis patients may be indicative of a chronic platelet activation, which we know is present in this population. So overall, platelet activation is different between the systemic sclerosis patients and VEDOs patients, indicating that platelet activation changes throughout the disease course. So it's not the same going from the early stages of the disease to an established disease. Platelets from patients with VEDOs, once again, exhibit increased activation upon convulsive stimulation, whereas platelets from patients with established systemic sclerosis respond more strongly to ADP. And in the future, with larger cohorts of patients, we'll be able to further characterize platelet function across different disease stages and disease severities, which will be important for the development of targeted treatments. So targeting not only specific platelet receptors, but also specific platelet receptors which are more important at a specific disease time point. And that's it. Thank you.
Thank you, Alessandro.
Thank you.
Very nice work and very passionate presentation.
Thank you. I know it's...
Yeah, are there questions for Alessandro? I was just wondering, so
Yes.
Since the state of activation is variable according to the disease status,
Exactly.
and also the mechanism of activations are variable according to the disease status, or?
The mechanism of activation is the same. We just, whenever looking at platelet activation, we look at those two markers.
Okay.
So we usually look at them separately at first to see, because integrin activation and alpha granule secretion are both markers of activation.
Okay.
But the part about integrin activation is more related to platelet also interacting with endothelial damage and interacting with other cells. And then we look at them together. So the activation is always the same. It's just that they are more active with different agonists. That was my main point, because it seems that in VEDOs patients in the early stages of the disease, endothelial damage is more important. For this reason, when there's endothelial damage, there's exposure to collagen, so the platelets bind more to the collagen and are more active. That's the main point.
The substrate for targeted therapy.
Exactly.
Okay.
Thank you.
Very
Thank you.
much. The last candidate for today is Sarah Chillemi, who did let's wait a little bit. Who did her thesis work under the supervision of Professor Paolo Palange, who's going to present her.
Supervision of Paolo Palange and Letizia D'Antoni, who is the chief of the respiratory neuromuscular outpatient clinic.
Wow.
So, a patient with amyotrophic lateral sclerosis die because of respiratory failure. So now the use of non-invasive ventilation may represent a bridge to tracheostomy and invasive ventilation. So we know that the early use of a non-invasive ventilation may change the quality of life and also the mortality of these patients. So the timing for the initiation of non-invasive ventilation is crucial. So there is several way to understand the moment, but Sarah in particular was interested in a new approach based on pulmonary function testing, and so now Sarah will explain how to do that.
Thank you very much for the kind introduction. Thank you to Professor D'Amati. Thank you to Professor D'Antoni and to all the members of the Commission. My presentation is called Expiratory Reserve Volume Postural Changes Predict Diaphragmatic Dysfunction in Patients with Amyotrophic Lateral Sclerosis, Results from a Large Series. Let's start with some background. ALS is a neurodegenerative progressive disorder affecting both the upper and lower motor neurons, and it leads to respiratory failure, which is the main cause of morbidity and mortality. Early detection of respiratory impairment is crucial because we want to start non-invasive ventilation as soon as possible. This is due to the fact that when respiratory mechanics are altered, there is an increase in secretion that stay in the lung, there is an increase in pneumonias, an increase in atelectasis, and all of these leads to early tracheostomy, and which is the one thing we want to delay as much as possible. I want to introduce the next part of the presentation with a quote from Joseph Milik-Emily, which is a pneumophysiologist that in the 80s described inspiratory capacity as the Cinderella of all spirometric parameters. He meant that inspiratory capacity is something not really looked at but can hide a lot of value. So what test do we use in our clinic? We use spirometry and many other tests, but we focused on spirometry in this research. In particular on expiratory reserve volume, which is the volume of air that can be further expired after a tidal volume expiration. Inspiratory capacity, which is the amount of air that can be inspired after a tidal volume expiration, and vital capacity, which is the sum of the two. How did we arrive to the idea of our study? We started from a paper that was presented in 2025 by Attali and La Veneziana, in which they saw that when patients healthy patients go from sitting to supine position, there is an increase in inspiratory capacity, about 18-19%, a decrease in expiratory reserve volume of about 40-45%, and since I just told you before that the two needs to be summed to give vital capacity stayed insensitive, stayed quite the same. So they just hypothesized that this happens in healthy patients because there is compensation, muscle compensation. But they hypothesized that in patients with diaphragmatic problems, diaphragmatic disease, this does not happen. So we were led to wonder, can expiratory capacity and expiratory reserve volume postural changes predict the necessity of NIV initiation compared to classical parameters? We tried to answer this question with a monocentric retrospective observational study conducted in Policlinico Umberto I between January 2019 and March 2026. Our cohort comprised of 98 patients, 51 males and 47 females. In particular, they were mostly diagnosed at our neurological department at the rare disease clinic. We evaluated them at the first pulmonary evaluation, which we called T1, in which we gathered demographic data, clinical data, blood gas analysis, and spirometry. in particular spirometry both in the sitting and supine position. Our primary outcome was NIV initiation, which we call T2. So what were the results? The main results, these are the main mean values at T1. And you can see that blood gas analysis is still normal. But what's interesting is that while respiratory exchanges are still normal, there is already a dysfunction at the level of pulmonary volumes. In particular, we can see that the main postural variation in ERV is about minus 40%, as la Veneziana and Natali hypothesized, as la Veneziana and Natali said. The main postural variation of inspiratory capacity is only 11.2%, and the vital capacity variation is minus 0.8%, which means that what Attali and la Veneziana hypothesized is confirmed by this study. We can also look at the p-values, and we can see that there are significant p-values, obviously because, for example, for the main, from the blood gas analysis, because these patients were all affected by the same pathology, and also non-significant p-values, for example, for the MMI, which means that our cohort was chosen quite randomly. Another interesting result that we obtained at T1 is that we found a correlation between PCO2 and bicarbonate with vital capacity orthostatic, vital capacity clinostatic, inspiratory capacity orthostatic, and inspiratory capacity clinostatic. But this was found only in females. It was not found in males the same. Another interesting result was in analysis between T1 versus T2, and we found that higher supine vital capacity and inspiratory capacity were associated with a lower probability of NIV initiation. What's even more interesting is that inspiratory capacity clinostatic was even more significant than vital capacity clinostatic, which right now vital capacity is used as a standard. So why did ERV not emerge as a statistically robust parameter in our cohort? Possibly due to incorrect track positioning, incorrect respiratory effort, incorrect chest wall muscle mechanics, and this probably makes ERV a more heterogeneous parameter than inspiratory capacity and vital capacity related indices. So I ask you the question that I asked in the beginning. Can inspiratory capacity and expiratory reserve volume postural changes predict the necessity of NIV initiation compared to classical parameters? The answer that this study gave was no, but we found that, for example, there might be the need of some sex-specific guidelines, since right now the guidelines for NIV initiation are sex-specific. And we also found that what the main message that I want to pass is that there is no one single parameter that is used right now to determine NIV initiation. There are many parameters that are used. And so, EC, inspiratory capacity, can be a new added parameter. Thank you for your attention.
Congratulations for this study, which was presented very nicely. Are there questions from the committee? I only have if you don't know. I only have a curiosity. The reason why these parameters were more significant, but in women only?
This is a very interesting question. There are some hypotheses. One hypothesis is that since most of literature is based on men, when we get results, it's more possible that we see men's result as normal and women's result as abnormal, so that can be a reason why. But another reason why can be just because women have a smaller diaphragmatic excursion, so instead men have a bigger diaphragmatic excursion when inspiring and expiring.
Okay,
thank you.
Now it's time for us to take just a few minutes to discuss the score, the final scores. I'm sure you all agree it will take really a short time because all the presentations were extraordinary and the quality of the thesis, the way they were presented were really superior. So be patient, we will be back for the moment. la riprendo.
La prendo io, dai.
La prendi tu,
Dove
dai.
sta? Sul tavolo?
Vedo proprio di sì. Francesca. Vogliamo parlare con Francesco un attimo? Sono scordata. Lascia qua. Prego. Quello è quello del funzionamento. Sentite? No. Adesso, allora, si possa rimanere di qua? Questo è per... Ok. Felice? Vieni vicino a me. Ok. Which one is this one? Yeah, this one. Okay, so as I promised, it took really a short time because you were all exceptional. Part of your score is due to your grades, but everybody knows that life is not easy and a grade doesn't really mean anything, really. You are all excellent students and you will be all excellent doctors. And I'm telling you, well, I read on probably on your thesis a mother, but I'm not thinking of your mother, but you know, a mother must leave their kids, go away. For us, it's the same feeling. Now it's time to let you go. Not forever. I hope you will be in touch. I hope you will still be part of our community from wherever you will be. I hope some of you will stay with us in Policlinico, but I know that some of you already have their plans, and it's correct, it's true, this is an international course. But I'm sure wherever you will go, or wherever you will stay, you will take with you some messages, some learnings, and some examples from your degree course. I hope we contributed to make you excellent doctors, because now it's time to call you doctor, but you already are excellent doctors. And I want to thank all your family and the person you love, friends, spouses, fiancé, whatever it is, because I know how it's important to have a family who is always there for you, who supports you in difficult moments, and in the medical school, difficult moments happen often, very often. So it's important. Many of you are here. Some of you, unfortunately, are not here anymore, but they are here today, I'm sure. And so what I'm asking you is to be empathic doctors, is to be respectful, is to listen before speaking, is to be tolerant, is to be patient with your patients,
is to do your job without any limitation due to any possible reason. You are doctors. You will treat all human beings. Okay, and with passion and with attitude and with all the kindness you will, I'm sure you are able to show, because you are all very, very kind. And now it's time for me to leave the floor to Dr. De Ruggero, who will introduce you to the life of a medical doctor in Rome, but also in Italy. It's very, very important. This is an important moment because you know that you are becoming doctors and you are able to do your profession here in Italy. So we will welcome you from the Order of Physicians.
Thank you, President. It's always a pleasure listening, Julia. We are all very lucky to have Julia today like a president. So I bring to you the salutation and the congratulations of the President of the Ordine dei Medici di Roma, Antonio Maggi, who couldn't be here today, but he sent me. And really, congratulations. All your 18 presentations were very, very well done. Interesting, and congratulations, really. I only give you some tips. Remember that this degree now is qualifying for practice, so you don't have to pass an exam to be qualifying for practice. You have only to remember that you need to sign into a medical order, not only the Roman order. You can choose the order of your country where you live, residence of living, or the residence of your practice. So you can choose where to sign. But you have to sign because you can't practice without the sign. I only want to say another one or two things. On some theses of the past, I saw one thanks, very nice, thanks God, because it's end. Remember that today is not the end of anything. It's the beginning of a life full of study. Every day you will continue to study, because it's very, very important to follow the guidelines, and the guidelines changes every day. We are full of medical doctors who don't have the degrees, or if they have the degrees, they don't follow the guidelines. Remember to follow guidelines, and remember that in front of you, you don't have parts of a body, you're a person. Remember this thing. In front of you, there is a person. If you are tired because it's during the night, you are sleeping and someone needs your help, stand up. Stand up, go to visit the person, change some medicine, write on the clinic cartel, and do it even if you are tired, because it can change the life of the person, it can change also your life. Okay? Congratulations.
Umay Kafkas. Okay. The committee has evaluated positively your curriculum and your thesis work. For this reason, by the authority entrusted to me by law and under the power granted by our magnificent rectress, I today declare you Doctor in Medicine and Surgery with a final score of 95, and many, many congratulations. Nikki Deitri. Nikki, the committee has evaluated positively your CV and your thesis work. For this reason, today, by the authority entrusted to me by law, under the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 98, and many, many, many congratulations. Hassan Farah Tarek Mohamed Ahmed. Hassan, the committee has evaluated positively your curriculum vitae and your thesis work. For this reason, today, by the authority entrusted to me by law and under the power from the magnificent rectress of this university, I declare you Doctor in Medicine and Surgery with a final score of 108. Congratulations, darling. Ortensia Cagliazzo. Ortensia, the committee has evaluated positively your thesis work and your curriculum vitae. For this reason, today, by the authority entrusted to me by law and by the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110, and many, many congratulations. Elani Papari. Bravo. Eleni, the committee has evaluated very positively your thesis work and your curriculum. For this reason, today, by the authority entrusted to me by law and under the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score with 110 with honors. Congratulations. Carlo Chikaron. Carlotta, the committee has evaluated very positively your curriculum vitae and your thesis work. For this reason, today, under the authority entrusted to me by law and by the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors. Elisabetta Rosi. It's a Sapienza kid. Elisabetta, the committee has evaluated very positively your thesis work and your CV. You have been serving as a student representative, and your committee for our insurance quality committee has been invaluable. So for this reason, today, by the authority entrusted to me by law and under the power granted to me by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors, and many congratulations. Daglielo a lui però, poverino. Ok. Flaminia Mudu. Flaminia, the committee has evaluated very positively your thesis work and your CV. For this reason, today, by the authority entrusted to me by law and under the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 and honors, and many congratulations. Marco Martinelli. Marco, the committee has evaluated very positively your thesis work and your CV. For this reason today, by the authority granted to me by law and under the power entrusted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors, and congratulations. Anastasia, Erini, Msura. Anastasia, the committee has evaluated very positively your thesis work and your CV. For this reason, today, by the authority granted to me by law and under the power entrusted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors. Congratulations.
Francesca Lupi.
Francesca, the committee has evaluated very positively your thesis work and your curriculum. For this reason, today, by the authority granted to me by law and by the power entrusted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 and many, many congratulations and honors. Sara Chilemi. Sara, the committee has evaluated very positively your thesis work and your curriculum. For this reason, today, by the authority entrusted to me by law and the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors, and many, many congratulations. Rafael Capidino. Raffaele, there are no words to thank you for your commitment to our degree course in the skill lab. For every problem you found a solution in many, many situations. And this commitment has made our course better. So this is part of your CV which must be mentioned. And also you did your excellence path in this degree course. So we fully appreciated your CV and your thesis work. For this reason, today, by the authority entrusted to me by law and by the power granted by our rectress, I declare you doctor in medicine and surgery with a final score of 110 with honors. Many congratulations and see you later. Nadab Roa. The committee has evaluated very positively your thesis work and your CV. You are an excellent student, and as Elisabetta, you served as student representative, and this is a proof of your commitment to our degree course. For this reason, today, by the authority granted to me by law and under the power entrusted by our rectress, I declare you doctor in medicine and surgery with a final score of 110 with honors. Congratulations, and let me know you know what. Alessia Dto. Alessia, the committee evaluated very positively your thesis work. You are one of the most eclectic students we ever had, and we have to thank you for your commitment in promoting our degree course and also for serving as student representative for the Faculty of Pharmacy and Medicine. You did an excellent job. For this reason, today, by the authority entrusted to me by law and under the power granted by our rectress, I declare you Doctor in Medicine and Surgery with a final score of 110 with honors. And many, many congratulations. Stay with us. Margarita Flores. Margarita, what can I say? Again, you served not only as a student representative, but also as a tutor in the skill lab, and with Elisabetta and Raffaele, you helped a lot for the Amvur site visit. So again, thank you on behalf of all the degree course, because you spent significant part of your time for us. And your thesis work was truly appreciated, as well as your excellence path, which is a part of your curriculum, which is an excellent curriculum. For this reason, today, by the authority granted to me by law and the power entrusted by our rectress, I declare you doctor in medicine and surgery with a final score of 110 and honors, and really thank you. Congratulations. Aurora Tasano. Aurora, again, thank you. You've been serving as a student representative with Margarita, following Nadab and Elisabetta, and also you did an excellent job. All our student representatives have been excellent. The committee has evaluated very positive your thesis work, and your CV, including your attitude to serve the cause. For this reason, today, by the authority entrusted to me by law and by the power granted by our rectress, I declare you doctor in medicine and surgery with a final score of 110 with honors. Brava.
Alessandro Vigna,
Okay. The committee has evaluated very positively your thesis work and your curriculum. By the way, you are the one who will read the Hippocratic Oath. Okay. If you don't mind. Okay. And for this reason, by the authority entrusted to me by law and by the power granted by our magnificent rectress, I today declare you doctor in medicine and surgery with a final score of 110 with honors, and good luck for everything. Papa. Now, this is a very important moment for everyone. Alessandro will read the Hippocratic Oath for everyone. You can do it here, but I'd like each one of you to turn and look at his family, friends. They are here for you, and we are all here for them. So this is an important moment. Many of the concepts in the Hippocratic Oath are kind of old-fashioned, but there is a very strong dedication and committee to ethics, which is extremely important in our profession. So please, Alessandro, go ahead.
I swear by Apollo, the healer, Asclepius, Ig, and Panacea, and I take to witness all gods, all goddess, to keep according to my ability and my judgment the following oath and agreement. To consider dear to me as my parents, whom you taught me this art, to live common with him, and if necessary, to share my goods with him, to look upon his children as my own brothers, to teach them this art. I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. I will not give a lethal drug to anyone if I'm asked, nor I will advise such a plan. And similarly, I will not give a woman a pessary to cause an abortion, but I will preserve the purity of my life and my arts. I will not cut for stone, even for patients whom the disease is manifest. I will leave this operation to be performed by practitioners, specialists in this art. In every house where I come, I will enter only for the good of my patients, keeping myself far from all the intentional ill-doing and all seduction, and especially for the pleasure of love with women or with men, by the free or slaves. All that may come to my knowledge in the exercise of my profession or in daily commerce with men, which ought not to be spread abroad, I will keep secret and I will never reveal. If I keep this oath faithfully, I may enjoy my life and practice my art, respect by all men in all times. But if I swerve from it or violate it, may the reverse be my lot.
Now we are having an extra picture. Ci fai una foto, poi mi scrivi a me, con la medical doctor, con la maglietta MD del corso F. Vai. Una foto professionale for social media. Tutti insieme. Okay. Perfect. Thank you. Now, le do il mio indirizzo. Li posta mentre. Grazie. Okay, so this is the beginning. The beginning of a partially new life. It's the beginning of a day full of joy and celebration. As I told you before, I'm asking you to live quietly, policlinico, and celebrate far from the words. Okay, thank you for being here.